Cek. Cek dari mic nomor 1. Cek. Tes. Cek. Kenapa ada feedback? Cek. Tes. Cek suara. Tes. Cek. Ada feedback ya? Cek.
Ini
Cek.
cek suara 1 2 3. Cek cek.
Cek dari mic nomor 1.
Oke, mic nomor 1 clear. Cek mic nomor 2.
Cek. 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 Cek dari mic nomor 2. Cek. 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 Cek dari mic nomor 2. Cek 1 2 1.
Oke, lanjut cek mic nomor 3. Cek mic nomor 3. Suara jelas.
Jelek tuh. Di YouTube jelek.
Cek mic nomor 3. Cek mic nomor 3. Cek mic nomor 3.
Cek dari mic nomor 4, apakah suara terdengar dengan jelas? Beda kan?
Jelas. Tadi samain aja pas.
Coba nyalain kameranya, siul.
Cek dari mic nomor 3. Cek dari mic nomor 3. Cek dari mic nomor 3. Cek dari mic nomor 3.
Ya,
Jelas.
mungkin.
Cek dari mic nomor 3. Treble mesti dikecilin, tapi ya pasti kecil jadinya. Tes.
Gitu ini buat penanya aja. Jangan digunakan.
Mohon cek mic nomor 4.
Cek 1 2. Cek dari mic nomor 4, apakah suara terdengar dengan jelas?
Om Swastiastu, selamat pagi. Om Swastiastu, good morning. Om Swastiastu, good morning. Boleh. Om Swastiastu, good morning to all the professor, doctor, and all the audience. I'm Titin, the second year's registrar from the anesthesia department. Welcome to today's lecture. Today we are so excited to attend this lecture. Today's lectures will be presented by our special speaker, Professor Stephen Paul Gatt. Um, tes, tes, satu, dua, tiga, tes.
No, it's not short. They're all for 2 hours. So, Everybody, for the first lecture, the second was this is one big Gatt. There's one Gatt, CS party. That's number 2. Okay. And then wellness is wellness party is number 3. Okay. You got it? There it is. Yes, good. The color is not right. So.
Morning, Prof.
Hello, Prof. Good. How are you? Okay. All right. Look at this.
Prof Andre. Yeah, okay. Okay. Yep. Okay. Okay. Om Swastiastu. Assalamualaikum warahmatullahi wabarakatuh. Shalom, namo buddhaya. Selamat pagi adik-adik semua. Of course to my best friends, Prof Stephen Gatt and also Prof Andre. So FID must to know that I told yesterday for Prof Andre and nowadays Prof Stephen Gatt. Prof Stephen Gatt is our. Sorry, I begin it. Sorry.
It's okay.
Prof Stephen Gatt is also our visiting professor. So, oh yeah. You know, you have all of you have seen the end of their photograph. Okay. So for today, every year's Prof Andre and Prof Stephen Gatt give us a lecture, and time twice a years also for that. So nowadays, Prof Andre also before the Indonesia, Prof Andre and Prof Stephen Gatt will give us a lecture, another lecture for that. Very important lecture for, because you know that Prof Stephen Gatt nowadays is a consultant also for geriatric specialist also. Okay. Our lecture will be break at 9:30, Prof Stephen. So we will go to our dean in the medical faculty. Okay, jadi tolong nikmati diskusi ini. Beliau itu baru dapat briefing tentang geriatric specialist. Ya, okay, please, Prof Stephen Gatt.
Did you want to say something?
Yeah, it's okay. You may start, Professor. We would like to say welcome and good morning to all the participants and the professor and doctors. Today we will start our first lecture by Professor Stephen Gatt. The first topic will be anesthesia for the frail, super frail, and compromised elderly. Professor Stephen Gatt, please.
Good morning. Selamat pagi. I've been here many times. In fact, the first time I came to Bali was 47 years ago. Indeed, I was staying today at the same hotel I stayed at 47 years ago. That's the same time almost when I arrived in Australia from a little place called Malta, a country south of Italy. Now, I love to see these colors in the rooms because the guys in pink know nothing. And you guys in blue know everything, right? So it's always very good to know who's who. Perhaps the guys in the blue in the back should move to the side, please. Okay. Now, today I want to spend about 6 hours with you, actually, all day, effectively, and feel free to invite your friends to come as well. The first lecture is about the elderly. The second one is about obstetrics. So if you want to bring obstetricians for the second lecture and so on. And the third one this afternoon will be on wellness, on how to be healthy in your departments, on how to make your departments work. Now, normally I walk up and down the side. I think they put an obstruction here for me, so I can't get through. But normally I walk up and ask specific questions to everybody. It doesn't matter if you can't answer, right? I'll always go to the clever ones first on that side. I won't disturb you too much, all right? Because you know nothing, right? But as we do this, I want to point out several things that are important to me in the way that anesthesia is developing. What is so different about my lecture as opposed to reading something from a book, right? And in order to start, this morning we have one complication. At 9 to 9:30, I think we need to go and see the dean. So what I propose to do is spend most of the first half an hour doing the introductions, right? And perhaps we can start on the lecture eventually. Having said that, I think we'll then stop at 9:30 and then we'll start off doing about 2-hour blocks on every occasion. Now, I often send stuff over here for you guys to do things with, right? And I usually insist, I usually send the education section of the British Journal Anesthesia. I send them to Prof. Weir, I send them to Prof. Chock, and so on, right? And Prof. Swastika in intensive care. And again, I'm very happy if you leave them running around over here. Today I've brought you 2 copies of my, well, I shouldn't call it my book, because actually 3 people, and I'm at the one at the end, you know, the one who does nothing, you know. But anyway, there are 2 copies here. Please leave them in this room, you know, just use them whenever you feel like. I think that's important. I've also brought you something rather strange, and this is to do with dental damage. These are sets of things that you peel off and put into your anesthesia chart in somebody who has bad dentition. Because if eventually you knock out some teeth or you crack some teeth, then we know that perhaps it wasn't you at all. Perhaps it was very bad dentition from the patient. So in Australia, this has assumed very large things. We now use those on our anesthesia record itself, right? So I'm also going to leave you this with the stickers, because this can go directly onto your anesthesia charts, and it's to do with dental damage. I'm not going to talk much about dental damage. I've done that once in the past before. Okay, having said that, I think we can now start. Is it possible to move that a bit this way or somewhere, so I don't have to knock it over every time I go past? And I will walk up and down, don't worry. Okay, today I'm starting off with this. This is a brand new topic for me. Professor Van Zundert and I, in this last year, I'm 71 years old. You'd wonder, what the hell am I doing? A Master of Science in medicine, you know? And it's basically, this is the topic. It is the elderly. Why? Because I thought I had to change career now at age 70 to go from doing obstetrics, which is my baby, right, to doing the elderly, you know? I'm not going to be doing epidurals anymore. I'm not going to be getting up in the middle of the night to do cesarean sections. So perhaps the better way to go now is to do elderly. The difference, the elderly, as I'll show you in a moment, are a very interesting group of people, because you think that they are just people who you know, are old. But in anesthesia, we can't treat them as people who are old at all, because they become much more difficult to do things with. They become much more difficult to treat. And if you treat them the way you do a young person, they will die. Especially this lot of people called the seriously frail. This is where I come from. That's my hospital and the University of New South Wales next door. It's 2.5 kilometers across the hospitals, and a further 2.5 kilometers across the university. You need a car, basically, to get around in the hospital, right? In terms of number of beds, we don't talk beds anymore in our hospitals, because the number of occasions of service is so much bigger than the number of beds. Most stuff is done as day surgery, very short acting, and in the second lecture I want to talk a bit about ERAS. In fact, I'll talk about ERAS in the elderly as well. So that's actually not one hospital, it's a cheat. because this hospital, let me see, is this the one I need? Yes. This hospital here is the Sydney Children's Hospital. This hospital here is the Royal Hospital for Women. This is the Prince of Wales Hospital, all over that big over there. And on the top here is the Prince of Wales Private Hospital. So we have everything on this. We've got mental health, everything you can think of. And in Bali, you're lucky, because in Bali, you very much operate like this, in a way. Large numbers of staff, very organized, you know, in everything that you do. These are my disclosures. You're obliged at the beginning of the first question, you know, who do you work with? You know, what are the drug companies involved? I can assure you that just about every single drug company in the world is sitting in there somewhere. I've done something for them. I've gone to lectures for them. I've done all sorts of things. But anyway, nothing I tell you today has anything to do with any of these companies, I can assure you. Now, the one big thing that's happening in anesthesia currently is ERAS. Right? What does ERAS? So this is an ability to run patients through hospitals as fast as they possibly can. This is an invention of the surgeons. It's surgery, right? This is an invention of their group of wanting to get the people through the hospital as fast as they can. Why? Otherwise they can't operate. Otherwise they haven't got time to do things. Otherwise they don't give them operating theatre time. So the facility has changed. But the first thing and most important is prehabilitation, right? We're talking of patients. Let me see. How do I go back now? Let me see. No. How do you go back with this? I talk to you, right? Okay, I get it. Okay. What do we try to do with patients, therefore, to try and get them through hospital as fast as we can? And the first and most important thing that we try to do is we try to make them much better before they arrive. I have an old friend, and Andre's friend as well, called Heinrich Kellett. And this guy invented something from Denmark, which involved, his policy was, if you go and become an athlete at the Olympic Games, right? You go and prepare yourself to go to the Olympic Games. You train, you go to, but when you go to surgery, they sit in bed like this, doing nothing. These are the worst people to operate on, the people who are not fit, the people who are sick, right? And yet most of these people that come to surgery don't need to be unfit and sick. So what can we do? The first is we want to improve their function, right? Secondly, we need to make sure that they're eating well, that they're getting the protein they need to heal their wounds after surgery, right? We need to change their lifestyles to become healthy. We don't want them to smoke. We don't want them to take huge amounts of fat every day. We don't want them to be morbidly obese. Not many of you are, but plenty of ours, well, not as much as the Americans, but certainly. And we also want to manage their levels of stress. And this whole package is called prehabilitation. Now, what is the value of age from anesthesia's point of view? If you're 70, I'm a bit poorly, but most of you guys are pretty good. But what I'm saying is there are 70s and 70s, and there are 60s and 60s, and 90s and 90s, right? And to us, chronological age means nothing, absolutely nothing. Because what you want to do is, everything that you read in your books always says young, elders, 65, young, 65 to 74. I'm still in this one, thank God. Middle elders, 75 to 84. Old elders, 85 plus. But this is of virtually no value whatsoever. This is how you make demographic charts for idiots who are sitting in the health department to decide how to manage people. But that's not important. What is important is what is not chronological age, but it's functional age that we're interested in, right? And again, there's a big article on Clinics of North America that shows us what to do. And this is also important, not only in surgery, but also in prescribing for post-operative pain, for example. What do you prescribe for a 90-year-old as opposed to a 60-year-old is irrelevant if the 90-year-old is acting like a 60-year-old. Do you get the message? Good. Now, the other thing I want to talk about today is frailty. There is a group of people, right, especially what we call the super frail, where, right, if you try to operate on them, they always die. These are the sort of people where you blow at them and they die. I mean, that's the sort of people I want to talk about. How does an anesthetist manage a guy or a woman who happens to be 95-year-old and is so frail that any surgery they do on them basically is either a life sentence in terms of being transferred from home to a nursing home somewhere, a person who develops such bad cognitive dysfunction after the surgery that they're not there anymore, they're not home, right? How do we manage these people? What drugs do we need to give them to make sure that this does not happen? And this is a very common phenomenon. I don't know how many of you, for example, if you have somebody who falls at home and fractures the hip, what proportion of those people actually ever go home again? What proportion of those people die? It's very high. You'll be surprised how high it is in these frail people. Now, when you look at function with increasing age, right? If you look, for example, this is age 30 to 90, right? This is age 30, and that's age 90. Now, if you look at certain things, like the lungs, for example, maximum breathing capacity, right? Sure, it goes down to 30% eventually of normal function. But the lung has big reserve. So even at 30%, you can probably operate reasonably well. After all, you can do a pneumonectomy and take out one whole lung on a 20-year-old, and they live fairly normal lives, right? So it depends on how much capacity you have, how much reserve you have. Is that this yellow one, the one you can't see, is called the marathon record rate. This is the best that persons can do in terms of exercise, right? And as you can see, it goes down to 50%, but the 90-year-old still retains a good 50% of the capacities. In terms of nerve conduction velocity, for example, it remains almost intact. The 90-year-old cannot be assumed to be cognitively impaired, right, and having damage to their, simply because they look gaga, they look elderly, right? Some of them will be doing fairly well. And even with the basal metabolic rate, for example, the blue one, right, you can see that the diminution is only about 15%, right? The metabolism is going fine, even at age 90. But that's basing it on age, again, not on function. Now, Jeff Cutfield once produced these sort of things, right? And this is the percentage decline from 20 to 30 years to 60 to 80 years. What happens to all of these things? Body temperature, no change. Total number of neurons, right? Resting pulse rate, and all the other things. The things to note down here, which is 40%, for example, right? This is the decline, remember, how much it's gone down. So, for example, total number of neurons has only gone down by 0.20%, right? In a 60 to 80-year-old. However, if you look at things like number of alveoli, right, as I showed you already, right, again, it's gone down to 30 to 40%. And the one thing that's of very great importance is this one down here, the GFR, the glomerular filtration rate. Kidney function does deteriorate with time, with age. You lose glomeruli. No, it's all right. I'm looking at that because we have to go to the dean at 9 o'clock. So what we're going to do very shortly is you go get lost 9:30. Good. In the case you guys get lost at that stage, go and have a cup of coffee somewhere. Okay, and I'll come back half an hour later, and we'll carry on. In the case, let's keep going. So, how frail is an elderly person? Why is it so important that we know exactly how frail they are? Why is it so important that we have a different classification of patients, not called elderly anymore, right, but called frail elderly, or called so frail that, as I said to you before, that you will die if I try to do anything on you and give you any drugs at all, right? And there are a number of ways in the perioperative setting where we can assess these, and some of them are so extensive that it takes a whole day to do the screening. And we have special nurses who do nothing but do what is known as comprehensive screening and there's a report. It says this person has a score of, right? There are so many screening tests that it's almost mind-blowing how difficult it is. And there's those that assess the elderly, those that assess the frail, and then those that assess the super frail. But, you know, what is assessed mostly in these things? And I'm sure you have these things already in your own hospital charts. They're there. The nurses do them every day. Do they need glasses? Do they need hearing aids? Do they need this and do they need that? But basically, most of these testing is, for example, falls, right? And this is the frailty syndromes. They look at continence. Do these people, you know, are they continent or incontinent? Are they confused, right? And there's always questions like, do you think that you've confused a name recently? I did it this morning with Nelson. You know, I couldn't remember from last night, right? And so on, all right? Function, right? There's a whole index of activities, the Burton index, that looks only at activity on a day-to-day basis. There are the activities of daily living, right? Are they continent with the bowels, with the urine? Can they clean themselves? Can they groom themselves? Do they feed on their own, or do you have to feed them? You know, and so on and so forth, right? But also there's an assessment of burden on the carers, on the nurses, on the, you know, how long does somebody have to spend with their relative every day to care for them? You know, those sort of things. But there's also screening tests for cognition and delirium, because the biggest problem with the elderly after surgery, right, is to do with acute confusional stress, post-operative confusion, post-operative delirium, post-operative cognitive decline. Why? Because basically these are the sort of things where people deteriorate so much, right? And so when it comes to these fragile years, you know, what is different? What is different about these people? These are frail elderly people, not just elderly. They are frail elderly, right? So we have to plan certain things for them. We have to have a person-centered approach, because this person is special. This person is different, right? We have to have early discharge planning. You know, we have to be able to work together to do things, and we have to try and make them independent as much as possible. Some people, you know, can go from a nursing home after surgery, having done prehabilitation, back home after the surgery. It doesn't always have to be a one-way traffic towards getting worse. You know, these people who are lonely, at home, on their own, not eating well, and so on, can be turned into people who are not productive, perhaps very much, but at least independent, okay? So to me, of special interest to the anesthesiologist is to be able to identify the frail elderly, to identify those who are more likely to develop cognitive dysfunction and acute confusional states, and also to look at the possibility in some people of hemodynamic instability before, during, and after surgery. These are the people who need special monitoring. These are the people who need to have to lie for 24 hours, 48 hours, sometimes a whole week in an intensive care type setting, which nobody grants them. Nobody grants them this intensive care setting. Why? Because we want the beds for the motorcycle accidents, you know what I mean? We want the beds for other things. And I'm an intensive care specialist. And so, you know, I need to implement strategies to reduce those big risks. Hemodynamic instability, which obviously we're very interested in surgery. When it comes to anesthetists and surgeons and so on, remember that you will always be the carers for this hemodynamic instability, even if it takes 2 weeks after surgery to do so. This business of us giving anesthesia and then dumping the patient back on the surgeons who have no knowledge often of these things at all. They don't know how to deal with hemodynamic instability, honestly. I've worked with many of them. Some of them are absolute idiots when it comes to these sort of things, absolute idiots. Because they've not been trained in that. They know how to tie knots, you know, but they don't know how to do much else. Now how can you guys assess frail elderly coming up for surgery, right? So basically, we have modified for ourselves, we've made a modified frailty index, which is known as the MFI 11. And you can score the following variables, right, from all of them. And there's a number of scores that you give to each. You divide everything by 11, and then you say, this person is pre-frail, frail, or seriously frail. Okay, and those three groups of people have to be managed differently by anaesthetists at all times. They're not the same type, not the same body, it's not the same person at all. Now, a lot of it is derived from stuff, right, that is there, obviously. You know, this is a diabetic with congestive heart failure, right? Hypertensive on meds. They've had strokes in the past, or TIAs. They've had history of myocardial infarction. They've had CVAs. They've had chronic pneumonias and bronchitis and chronic obstructive pulmonary disease. They've had coronary artery stenting, and they've got an impaired sensorium. I sort of score almost 100% on all of those, but not quite frail yet. Now, the one test that I do, and I think it is as simple as hell, and that's why I recommend it to all anaesthetists, because we don't have the time, basically, often, unless this work has been done before by the geriatricians, by the surgeons, surgical teams, and so on. The one test that I use is this one. It's called TUG. The TUG is a timed up and go test. A chair, right? A marker at the end of it, right? Or another chair. And all I say is, I give them 15 seconds to get up, go around this chair, right? And come back and sit down in the chair. So they have to do a sit to stand. They have to walk 3 meters. So the distance between the two chairs or the hat, the traffic hat, is go around the hat and come back in your chair, turn around the post, whatever it is, walk 3 meters and sit down. Requires no equipment at all. 2 chairs is fine. Okay? But the message is, get up, walk, go to the other end, right? And come back and sit in your chair. Now, what does this test? It tests a huge number of things. For example, cognition-wise, it tests whether you can get up and understand the instructions I've given you. If you don't understand the instructions, you won't get up. So already you failed your test. It looks at physical activity, and you might have to make some adjustments to this if you have somebody, for example, who's an amputee, who only has one leg, right? And has to get up on their frames and so on. But if they can walk up and do it and come back and do it perfectly, then don't worry too much about them. They're cognitively all right, they're physically all right, right? And they don't have all the other things, Parkinson's and Alzheimer's and so on. Now, this is something I did for myself, actually. I assumed that I was born in 1952, that makes me 70, as I said, 71, all right? And I assumed that I'm going to die next year. Does that make sense to you? I don't intend to die next year. In fact, I went to my accountant a little while ago and says, how much, I said, how much will my money last me when I die, till I die? And I said, when do you want to go? I said, till I'm age 116. Oh, he said, my program doesn't do that. It doesn't know what 116 is. I said, all right, give me what you have. He said, 106. I said, good, all right. So he's done it for me. So I'm not going to die next year. I'm not like, but let me take an ordinary, sorry. Ooh, what have we done here? Ils ont changé ma chanson, ma. Oh, no, sorry, we're back. Sorry. Perhaps we are in the right spot. Anyway. Okay, so, all right. If you look at England, for example, running from 1541 to 2241, right, you see that in 1541, the population was the same as in 1941. Across England, this is the war years, so the next year it dropped, right? But between 1841, so until 1941, and now we're talking about what we call the baby boom, there was no increase in population really at all in the United Kingdom, at all, right? And that's over 600 years, you know, nothing. And then in my lifetime, I can anticipate, which goes from there to there till I die next year, right? I can assume that the population is going to keep rising. So this issue with the elderly is going to be a problem that you'll have, because you were born in the 1990s, or and perhaps some of the guys on this side even after that, right? And so you can see that it won't be till about, I think, about 2050 that it'll start to plateau out again, when medicine can't do any better, where perinatal medicine can't do any better, where unless we invent something really great, and we live forever, and then it's going to be easy, you know what I mean? Now, I started off this thing with that first slide. What can we do now? Not so much as to assess and screen patients, but to see if we can make functional improvements, nutritional support, lifestyle modification, right? All of those sort of things. What can we do to make them better for the patient before they come to surgery? And this is a big challenge that we have, I think, in doing that. So let's go through that again. For example, what can we do with nutrition, right? We can give them dietary advice, right? We can give them packs with supplemental protein, the vitamins, electrolytes, fish oils, that sort of thing. How do you do this? Well, you make sure that they get enough nasi goreng every day, you know what I mean, and gado, that's true. But what do we do to supplement them with doing something good for them, right? What do we do with lifestyle, right? Don't stop smoking. If they're big alcoholics, give them some alcohol advice. Make sure that some surgeons in Sydney now will refuse to do surgery on patients who do not stop smoking or diminish smoking dramatically. Nothing, they refuse to do surgery on them. That's all there is to it, right? Again, sleep is very important. People who run themselves into the ground without sleeping are doing themselves a great disservice, really. So there are a lot of things, even lifestyle-wise, that we can do, right? Now, what can we do about distressing? Again, psychosocial support, reduction in anxiety, relaxation techniques. These need to be done for 5-6 weeks before they come to their surgery. As I said, this is the Olympic Games now we're dealing with here. They're going to have the coronary artery bypass grafts done, and yet they're unfit. Again, when it comes to function, for example, we need to start writing scripts for exercise. They need to go to the gym. They need to go and walk on the beach. They need to do all those things. They need to have supervised movement if they're elderly. And also we need to give them home support to be able to support all of these functions. So we now have, in the frail elderly, prehabilitation before surgery, doing all these things. They need to have a preoperative review of their medication, and then we need to choose the right anesthetic for these people. Do you get the message, everybody? If you don't, please stop me at any time, and we'll go over whatever you're unhappy with. So the anesthesia techniques need to be tailored to the frail elderly. We need to tailor the preoperative analgesia. You need to tailor their intraoperative analgesia. You need to tailor their postoperative analgesia, for example, right? And the techniques themselves have to be the best techniques that we can possibly produce for them. And I'll show you very shortly, perhaps in the second part of this morning, how to do this. Now, ERAS is an interesting thing. ERAS, as I said, is a rapid movement of patients through surgery. There are a number of requirements that the surgeon must do, right? They must do pre-admission counseling, optimizing their medical conditions, which none of them do, mind you. Don't get me wrong. This is what they're supposed to be doing. They need to avoid bowel preps, which dehydrate them. They need to manage their hydration. They need to avoid periods of prolonged fasting. These are not good for patients, right? Keeping them MPO for a day and a half or two until their laparoscopy comes up is disaster to these patients. They need to drink, they need to eat until an appropriate time. We need to administer preoperatively perhaps non-opioid type analgesics to manage their pain, if they have any pain pre-op. Intraoperatively, they say standardized anesthetic protocol. what the hell is a standardized anesthetic protocol? I have never given two identical anesthetics in my life, in 40 years, 45 years. A standardized protocol in anesthesia means that you tailor it exactly to the patient. The best you can do for your patient is what you want to do, right? Again, perioperative fluid management, of course, thromboembolism prophylaxis, antibiotic prophylaxis, use minimally invasive surgery when you can. And anyway, these are whole blocks of things. Early oral nutrition post-op, early mobilization, early removal of all catheters, urinary catheters, IV lines, and so on. Stimulate gut motility, right? Optimize glycemia control with insulin if necessary, you know? Those sort of things. But which ones actually involve anesthetists, right? Perhaps this one, non-opioid analgesia pre-off, what is known as preemptive analgesia. Sorry, can you see? No? Perhaps this one, standardized anesthetic protocol, which doesn't exist. We don't have an anesthesia protocol for everybody. I mean, you have, you know, a multimodal approach to post-operative nausea and vomiting. I agree, that's our job. And perhaps this one down here, non-opioid oral analgesia. But that's the role of the anesthetists in ERAS. This afternoon I'll talk a little, or later this morning we'll talk about cesarean sections. What does ERAX mean? ERAX is ERAS for cesarean section, right? There's no such thing. It's a nonsense. It's a piece of, it's something that we've been doing for 30 or 40 years. It's something surgeons invent, you know what I mean? But it's useless. It does nothing. Now, this is what has changed in anesthesia to me. And I might even show you the slide again later on and remind you about this. There are anesthetic techniques now, some of which you might have or might not have, right? But which you must absolutely get. Because now there are many combinations of things. Like, for example, total intravenous anesthesia, where you can combine a drug like propofol, where you can combine a drug like propofol with a drug like remifentanil, right, and the rocuronium infusion to produce anesthesia without having to use inhalation agents, which are quite dangerous in some of these patients, right? You can have, for example, now the propofol can be in preloaded syringes ready to go. You can have a syringe driver called the deprefuser, and using the Marsh algorithm, this machine will be able to deliver propofol at a set rate depending on the weight of the patient and the frailty and so on, and has different targets. Likewise, the remifentanil, for example, can have a programmed, what is known as a remifuser, and this time we don't use the Marsh, but the Minto algorithm to be able to produce a continuous remifentanil infusion, which when stopped at the end of the operation is not there at all within 90 seconds. There's no remifentanil left 90 seconds after you finish your anesthetic. But to do this, we also need a number of these. We need the syringe drivers, for these guys, the remifusers, the deprefusers. We need to have inline check valves so we don't get reflux into the lines. We need to have three-way taps with anti-reflux devices, so the drugs always go in the same direction, right? And that delivers usually through a central line. Again, now we have the combination of rocuronium up here, right, with sugammadex, so that we don't have to use all the nasty neostigmine sort of type preparations. So these are what's happened in the last 15, 20 years. I've given anesthesia using all of these things every day of my life for the last 18 years, right? And they'll come to you, don't worry. They have to come to you eventually. Why? Because this is very superior anesthesia all around and has lots less. But think about it, you know. Have we forgotten how to tailor perioperative analgesia to the frail elderly? You know, if you have a frail person, right, what do you do differently every day to change the pain relief that you give them? What have you done to change those things? And, you know, you think that suboptimal pain management is not too bad, right? Even if they have a bit of pain. Well, they have a bit of pain, you know what I mean? But this is not true at all. For example, if you look at morphine, for example, right? Right, and these are 10 milligrams of morphine, not too bad. 20 milligrams, right? Total. This is a total dose in one day. Many people would think 10 of morphine, right? What does difference is going to make? You know, what? So what? You give them 10 a day. All right. So basically, you think, well, not much difference really. You think about, 25 milligrams of morphine a day. But remember that for every time you increase this by 3 to 4 milligrams, the number of complications you get from that morphine, you get one event. If you go past that 25 milligram dose per day, you get 2 events by increasing it to 30, right? And you get 3 events if you go past 30. That's how narrow the therapeutic index is for morphine when it comes to patients, right? Now, so you all know about the side effects of morphine: nausea, vomiting, drowsiness, dry mouth, constipation, dizziness, difficulty passing urine, confused, weakness, itchiness, and headache, okay? You can significantly reduce this, right? Significantly reduce this by adding something to that morphine, whether it's celecoxib, whether it's pregabalin, whether it's pregabalin, and this is one particular study. Whatever you do to reduce the morphine dose below that 25 milligrams per day is very significant in terms of reducing side effects. So morphine, in a way, is a useful drug, but also, sadly, it is one that has complications. Is it possible to stop post-operative pain, right, using analgesic cocktails? Well, if you look at it, especially if you do this before surgery, should you load up people with pain relief before surgery? Some people say yes, some studies say no. But why is this so? Why should there be a difference in opinions as to whether preemptive analgesia, as it is known, is important, right? All of us recognize that surgery represents a substantial and prolonged nociceptive insult. There will always be pain after surgery. It is only the surgeon who can modify that, but it's also the patient that can modify that to a certain extent. From our point of view, we then have to deal with the residuum. I think I'm frozen. Perhaps I'm too far away. Let me see. Too far away. Okay, there we are. Now, when it comes to ERAS, there are some drugs that you have in anesthesia which are absolute magic. If you want to make your anesthesia so clean and so fast, right, that it doesn't involve anymore giving a bit more halothane or sevoflurane or whatever, right? Where you want your anesthesia to have a patient at the end of your operation that's clean as a button, that's not confused and disoriented, that's not any of those things, then we have some real star drugs, some of which you have not got access to. And you will not have access to until people like Andre van Zundert, for example, designs for us a reversal for propofol, for example, right? A reversal agent for propofol, right? And he's working on it. Trust me, I know. Right, but there are some drugs that are really star drugs. For example, remifentanil and remimazolam, right? So we now have a morphine for anesthesia. Nobody else has this, right? 10 minutes. What happens in 10 minutes? I said, but really, okay. In that case, shall we stop now, Prof? All right, good, we'll stop now. All right. Let me wind up this first section, right? Sorry, good. All right, so, first of all, the short-acting drugs, right? The remifentanil, remimazolam. Then there are drugs that are reversible. For example, you can have your neuromuscular blockers, rocuronium and vecuronium, which can then be combined with sugammadex. Then we have the high-potency agents, the non-depolarizing muscle relaxants. We had the rapid clearance agents, inhalation agents, some of them anyway. Medications which don't produce drowsiness, like paracetamol, for example, being used for analgesia. the non-opioid oral analgesics. And if we can combine these things together to produce the ideal anesthetic for a particular patient, then so be it. I think I want to stop there, right? Because I need to talk about administrators next, to give them a hard time, I mean. And we'll reconvene at 10 o'clock. Okay, so let's stop here. You go and have coffee, whatever you have at this time of time. Do your pills, that sort of stuff, you know.
Yes, okay. Thank you, Professor Stephen Gatt. For now, we will stop right here and we will have a break and we will continue the first topic if Professor Stephen Gatt.
Not too far.
I think my lecture yesterday was a very good introduction.
Yeah, that's right. That's right.
Okay, we will continue with the break for now. And we will continue the first topic after Professor Stephen Gatt get back from the faculty. We will continue around 10:30. Around 10.
Yes,
Yeah, we will continue around 10. And all the participants may have the snack for now.
Okay.
Yes.
Good break, friend.
Hang on.
Oh, yes.
If the audience have any question regarding the first topic, the question could be asked in the Q&A session in the second topic. Thank you.
We're going to the DC.
Oh, yeah.
Okay, good morning to all of us. We will, in a moment, start again to continue our first topic today, regarding the elderly topic, the anesthesia for the frail, super frail, and compromised elderly. Okay, Professor Stephen Gatt may start.
I'm sorry, I'm a bit late, but these guys are very slow. It wasn't my fault. The traffic, thank God, is improving very much in Bali. Okay, we'll take up where we were this morning. Only to say that this meeting we had with the Dean will one day be of great benefit to all of you, I might add, especially those of you who might eventually decide that they want to do anesthesia research and stuff like that. Anyway, so we're saying that there are a number of star drugs for ERAS, and these also happen to be the same star drugs as those for the elderly. So for example, let's take ERAS. ERAS has been developed mostly for colorectal surgery, those sort of things, lower GI, upper GI, right? And this is what do you need to do to produce ERAS? What do you need to do to make management and anesthesia for the elderly different to everything else? And of course, a lot of it depends on hospital administration and whether they have an improvement team, whether the coordination team, and whether they have senior leaders who ultimately will be able to pull all our skills towards dealing with these individual patients. Now, I was talking earlier on a little bit about preemptive analgesia. And I said some people think that preemptive analgesia is a good thing, and some people think that it's not a good thing. Now, I hope you understand what preemptive analgesia means. It means giving people pain relief medication before surgery, and then during surgery, and then after surgery, so that you don't have to load them up with big doses after surgery. Why is there so much problems? Well, I think first of all, there's a problem with nomenclature. The use of preemptive is perhaps, it doesn't have a definition. And again, every study chooses what parameters to decide whether this thing works or does not work. And again, when you do research, you do drug A against drug B. But anesthetists don't work that way. We use drugs A, B, C, D, E, and F in every case. So you can't say that one drug doesn't work. When in fact, in anesthesia, we don't use one drug doesn't work. We use a number of drugs, all of which do work. So basically, when you're studying one drug against another, or a drug against a placebo, then the dose of the drug that needs to be used to produce that effect is usually very, very high, right? Compared to what we do every day. We use small doses of drugs combined together to produce a synergistic effect, right? So, and then also you have to look at the pain stimulus. How big is the stimulus? And the surgeons are trying again and again to do keyhole surgery, to do robotic surgery, all of which can reduce pain. So basically, it's one of those situations, you know, if you ask a stupid question in the first place, what do you expect to get? You know, rubbish in, rubbish out. You know, you don't get an answer to the questions that you really want to ask. Now, so is the magnitude of the intra and post-op analgesia, for example, drowning out the pre-analgesic effect in these patients? Or is every pain model the same, right? After all, is the pain of dental surgery, for example, the same as the pain of knee surgery, right? So basically, I'll talk to you a bit more about this one. Is it the fact that you can't use one medication preoperatively? You might want to use 6 medications preoperatively in a much, much smaller dose combined together. So what I'm saying is preemptive analgesia probably does work, right? And I gave a lecture in 2021 so showing that there was a growing appreciation, right, at all times of what is now known as balanced analgesia, where you use a number of things. And so we now perhaps don't need to talk about preemptive mainly, but more about multimodal analgesia, about balanced anesthesia, preemptive and early intraoperative analgesia of pain relief. And again, we use a combination of analgesics for acute pain: paracoxib, paracetamol, an opioid like morphine, tramadol, ketamine, the NSAIDs, the COX-2s, pregabalin, gabapentin. You know, all of these things are all used together in the anesthetist's armamentarium. We don't use single drugs. Again, one thing that we have to stop is allowing acute pain developing into chronic pain. I'm sure you all know a lot about this stuff, right? And the other big principle is that using less opioids is a good thing for the patient. We don't want to develop side effects from pain relief using only morphine type drugs. Okay? When I say morphine, I mean a whole bunch of them. So so basically when it comes to choosing the poison that you want to use, always think of using as many agents simultaneously as you can. But in clinical studies, we only study one at a time, right? So we can't do anything else other than that. We can't study different combinations of things, especially when the doses for each patient are different for each of those things. Again, we have many things that have come recently. When I say recently, I mean 15 years ago in my case. Again, intravenous paracetamol, for example. Fantastic stuff, you know, best agent, much better than any morphine that you can choose. And it's just Panadol based, it's just paracetamol, you know what I mean? Acetaminophen. Okay, so again, this is Pefalgan, you know, and it's intravenous. You know that when you give 1,000, you get 1,000. You give 500, you give 500, you know what you're doing. Again, for people like us in Bali, for example, I talk a lot about pharmacoeconomics. What do drugs cost? And why do hospitals not buy them? Why do they always blame the cost of drugs as being where the hospital goes down? This is the biggest bit of nonsense I've ever heard, right? The cost of running hospitals has nothing to do with the sutures that the surgeon uses, with the drugs that we use, with the agents, and trying to save little things means nothing. What is the biggest expense in any hospital? You guys, your salaries. You know, the more residents we have, the more it becomes expensive. The more doctors we have, the more expensive it becomes. It's nothing to do with patients. It's nothing to do with drugs, right? The biggest bill in a hospital is one, the fixed cost of running the hospital, right? The cleaners, the porters, everything else, right? Everything else. The buildings themselves, the building stock. To give you an example of this, right? If you look at a single surgical procedure, how much does it cost to do a, let's say the cost is 100%. 1.3% of doing a surgical procedure consists of all anesthesia drugs, all anesthesia consumables, and all anesthesia disposables, right? So the stuff you throw away every day, the drugs that you use, and so on. 1.3%. And the variation, plus or minus, is 0.3. So if I do a spinal, right? If I do a spinal and use nothing but 1.2 mils of solution to do a thoracic spinal, for example, then the cost is 1%. If I use everything, propofol, target-controlled infusion, remifentanil total intravenous anesthesia, paracetamol, paracoxib, tramadol, a non-depolarizing muscle relaxant, my standard anesthetic basically, 3 antibiotics, 2 antiemetics, thromboprophylaxis, pain buster soakers, thoracic epidurals, and so on, right? And fiber optic intubation, Andre's specialty from yesterday, then it costs 1.6%. So the difference between, so the 1% is always there. It's the 0.6 extra, right? That goes from the cheapest to the most expensive. All that this says is whenever a surgeon says, don't waste this stuff, no, please use it. If it's just for the patient, it's going to be cheaper for the service anyway. If they don't vomit afterwards, then great. If they don't develop DVT and a pulmonary embolus, then great, right? But sorry, this is not very good. Okay, so what I'm saying is the pharmacoeconomics of things is very, very important. Now, also remember of what this compares to in other things. For example, if I use I have infertility, for example, right? So choosing Eras drugs on the basis of price is nonsense. An infertility drug treatment cycle costs about, in my place, about 80 million rupees, one cycle. It takes 3.5 cycles to produce a baby, right? Go on a term out of that. So you need 80, so it's about 285 million, okay, to produce a baby, basically, right, on the infertility program, right? An ampoule of recombinant factor 7A is 65, one ampoule of drug of 7A is 65 million. An ICU treatment with amphotericin B, for example, right? Look how big it is, right? This is, enormous numbers of rupiah. So what I'm telling you is, forget about the cost of drugs and anesthesia. It's not even worth discussing. The cheapest anesthetic is the best anesthetic that you can give. Okay? Now, we talked about regional anesthesia and multimodal analgesia, right? The multimodal analgesia model involves using a number of intravenous agents intraoperatively, right? And they're all there, alfentanil, blah, 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 combined often with a local anesthetic. And this can be a thoracic, an epidural, a pain buster, soaker, all those sort of things. But also other analgesia techniques like intravenous PCA or PCEA. Again, what is the aim of ERAS anesthesia, right? One, it's superb, the best you can give intraoperative anesthesia. For example, TCI, TIVA, with perhaps a bit of smoothing using a bit of local inhalational agent. There's no postoperative nausea and vomiting. There's excellent postoperative pain control for a prolonged duration. There's clarity of mind, the ability to make decisions for the patients early in the postoperative period. Right? Medications which do not produce acute confusional states, hallucinations, disorientation. And almost invariably what works is a combination of local and regional with preemptive analgesia, with multimodal analgesia, with postoperative multimodal analgesia, with regional, major neuraxial block, or local anesthetics. So what I'm saying is the best anesthetic is not one made up of local, all the blocks that Professor Van Zundert showed you yesterday. It's that with other things. It's not the best with drugs only. It's best with local, regional, and major neuraxial. Now, what happens if you don't treat pain well? To me, it has very serious consequences, right? And what are these serious consequences? Well, acute postoperative pain, right, leads to many clinical and psychological changes. And if the pain relief is not adequate, right, then this goes to that almost immediately, right? So what starts to happen? You get the patients not able to get out of bed and mobilize early, right? You get increased risks of DVT, of pulmonary embolus, of myocardial infarction, of coronary ischemia, all those sort of things. And eventually, what is the effect of this? Not just morbidity and mortality, but increased lengths of stay in hospital, readmission to hospital because you haven't dealt with all those things, a decreased quality of life, a decreased patient satisfaction, and most importantly for the administrators, is it costs a lot of money. You know, this patient who hasn't been managed well is going to cost them 3 times normal. It's not just so, you know, again, in an economics point of view, it is very bad news to not treat patients well. All right, now, you'd have to admit that not all pain models are comparable. For example, let's take paracetamol, right? 2 different groups of procedures, right? And this is a combination of all the paracetamol studies in the world, for example, right? One is dental extraction and oral surgery, right? And you can see that paracetamol is doing well, right? But if you use it for an episiotomy, for postpartum pain, for orthopedic surgery, then paracetamol doesn't do too well. Why? Because there are different types of pain. You know, it's not the same models. All procedures have a different type of pain pattern, right? And a pain profile. So that the effects of analgesia techniques and drugs is not the same every time. How well do I do pain relief? Well, I guess I do it like you guys do, you know. I give them something and then keep my fingers crossed and hope it's going to go all right, you know. Does it go all right? Sometimes it does, sure, but sometimes it doesn't either, you know what I mean? So on top, unless you're on top of that, so now come the very sophisticated techniques. This is the on-cue pain buster soaker. So it's a catheter which you put in major abdominal surgery, for example, but also for other things, cesarean section for that matter, right? And you then let it, there's a little bubble here, and that bubble is full of drug, that sort of style, and then it goes down the catheter and into this, the catheter which is sitting inside the patient. Okay, local anesthetics, nice, clean, runs for 3 days, and when it's all finished, you just pull the catheter out, and that's all. You know, for example, should we use pain buster soaker for shoulder surgery? Yes, all you need is 2 mils per hour. The reservoir is 100 mils that I showed you just a little moment ago. But if you're doing abdominal surgery at 10 mils per hour, then to get the same duration you need at least 550 mils, you know what I mean? So, yeah, different things work different way. Though in anesthesia, right. And most of the times we are providing very good analgesia. But on the other hand, you'd have to ask, are we doing it every time? And the answer is probably not, right? For example, these are pain guidelines, and this is done in comparison of 1995 to 2003, and now we're going to 2021, 2023, right? How many patients reported moderate to extreme pain following surgery? And surprise, surprise, in 1995, we might have been doing it better. Sorry. Come back. Right. In 1995, we might have doing it better. They had less percentage of patients than they had in 2023. And perhaps in 2021, with ERAS, it might even be going up, not down. Right? That keeping people in hospital for a long time was probably not such a bad thing in terms of pain relief. That these people are going, so they're, if you're talking at Moses and the Ten Commandments, I don't know if you have that sort of thing in your culture. I'm not sure what the equivalent is, but is that giving people morphine and hoping for the best is not a good way to go, right? For example, post-cesarean section in the United States, you get given a couple of tablets of oxycodone to take home with you, and everybody hopes that there's not going to be any pain. It doesn't work quite like that, right? So take 2 tablets and call me in the morning. What can ERAS teams do to stop people going from acute pain to chronic pain? Chronic pain is a very expensive, as any of you who are chronic pain specialists will know, is a very, very nasty piece of work. We can do something about it, and anesthesiologists can do it better than anybody in the hospital. We can dramatically reduce the conversion to chronic pain. And the remedy is cheap, not time-consuming. It can be achieved in the course of our ordinary daily routines using ERAS protocols. How do we stop this happening, right? How do we stop this, right? Well, first of all, we eliminate pain. We remove the opportunity for neuroplasticity. We mobilize them early. We decrease all fear avoidance behaviors. That's the aim. But how do we do it? As I've told you 100 times now, preemptive analgesia, multimodal analgesia, regional anesthesia, and good post-operative analgesia with good follow-up. That's how we stop them progressing to, so we need to then eliminate this pain, mobilize them early, and so on. Now, perhaps I don't want to walk you through all of these, but if you think about it, how do we do normal anesthesia? In my case, there are operations which require sedation only. There'll be immediate discharge after the end of the procedure. You have short procedures, DNCs, hysteroscopies, polypectomies, and so on, right? Within 2 hours, they're out of hospital. So they have the surgery, come in at 8 o'clock in the morning, by 11 o'clock, they're out. Then you have the medium procedure, lap choles, laparoscopic excision of endometriosis, and so on. Usually they come in the morning, go home in the evening, before or the morning after sometimes, if they're being done in the afternoon. Then we have the big surgeries, the abdominal hysterectomies, hip replacements, and so on. The patient in this hospital is usually no more ever than 4 days, right? And finally, we have cesarean sections, which I'll deal with this afternoon. Now, we need better pain management protocols, right? We have a limited use of fixed therapy plans, and the choice of analgesia in anesthesia's case might often be too late. It's done only in the ward when the patient complains. Now, that is a very bad way to go, right? We need, and almost all of these things rely on systemic opioids. They are not often very, it differs between hospitals, it differs between countries, But anyway, in the end, we end up with suboptimal pain management, right? Now, the total package, if you want, of what you have available to you to do things with is limited. I mean, but what we have, basically, is stuff we can do before surgery, what we call preemptive, and these are the drugs that you would use. You have all the drugs during surgery, and these are the drugs you can use. And we have post-operative pain, and those are all the things you can do, okay? So plenty of stuff for all of us. We can choose any combination of those things. And indeed, if you're a good anesthetist, you change it every day, every time. Identical anesthetics. Again, I've showed you this one, these are marriages made in heaven. And I've even translated it into Bahasa for those of you who can't get it. Okay, but this is, I showed you already. This is my Gatt's anesthesia heaven. Okay. The message in them is throw everything that you can at them, right? Every technique that you have that you think is going to be useful in a particular situation, just use them all. Pack as many chickens as you can onto your motorbike, right? Pack all this, let there be no pain, right? If you can use 5 different techniques simultaneously to take away the pain, do it. Because that's the cheapest for the hospital, it's the best for the patient in the end, and so it doesn't matter how you do it. Now, post-operative pain is a really strange beast, because not all of them apply, but some of them do apply in every situation. For example, some of post-operative pain might be referred pain from elsewhere. It might be a reflex response with muscle spasm. It can be cutaneous from the skin wound. It can be cortical responses in different patients. It's visceral pain. Sometimes it's deep somatic pain in muscle, in fascia, and ligaments. And again, sometimes it's actually not even pain itself. It's nociceptor sensitization, which then increases and multiplies the quality of the pain. So, and again, different procedures have different pain characteristics. Like, for example, you can have different types of pain. You can have different types of pain intensity. You can have different types of location of pain. And you can have the techniques themselves modifying all these different variables. And that's why analgesia is so difficult to manage, basically, for most people. This I've shown you already, right? And now, so what is the best multimodal analgesia that you can produce? I tell you, anesthetists are a very lucky bunch of doctors. Very lucky bunch of doctors. Why? Because at last we have every single agent that you might possibly want to use intravenously. Every single agent. The other guys fiddle around with, anticonvulsants, and they fiddle around with antipsychotic medication and all that sort of stuff. They don't know if these things work. They don't even know if patients are taking them. They don't even know. But we use intravenous everywhere, right? So if you look at them, we have the NMDA antagonists like ketamine. We have the TOX2 antagonists like paracoxib. We have the NSAIDs like ibuprofen. We have the central COX-3s in paracetamol. We have a bucket load of different types of opioids. We have the 5-HT and noradrenaline antagonists like tramadol, and that is known as balanced multimodal anesthesia. But we can do better than that, because we can then add local anesthetics, either additively or synergistically, to produce the best analgesia we can and reduce the side effects at the same time. Never in the history of anesthesia have we been in such a lucky situation. Nobody has better than this, right? And this has been going on for 20 years now. No, it's not something new. So it'll all hit you in your own lifetimes very, very quickly. Now, why do things progress from acute to chronic pain? I'm sure you all know this is probably coming out of your ears by now. But anyway, let's start off with a surgical nociceptive input. So this is intraoperative pain. The surgeon causes some damage, and you get some secondary inflammatory response, right? You then get an elevation of the prostaglandins. You get a cellular COX-2 rise. You get hyperalgesia. You then get postoperative pain. So you then amplify the postoperative pain. again, if it lasts for very long, you get central sensitization. That then causes spinal cord neuroplasticity, and then you get the chronic pain syndromes, the allodynia, the hyperalgesia, the neuropathic pain. Once you're there, game over. You've lost it, right? The patient will live all their lives with that chronic pain. They can do nothing about it anymore. The central nervous system has gone haywire, right? All the lights up there are lit up. They have chronic pain for the rest of their lives. If we can stop only this, it would be doing ourselves a great favor. And again, what I want to come to next, very shortly. This is especially important in elderly patients, because elderly patients do have pain. In fact, many of them have a lot of other pains from other things that's happened in the past, injuries, inflammation, chronic diseases, and so on. So, if you were designing drugs for the frail, for analgesia and anesthesia, what would you want? First of all, I'd want those drugs to be ultra short, absolutely ultra short acting, right? The medications, we want medications we don't require kidneys and livers to deal with. We want these drugs to just suddenly break down on their own. We want agents with very short half-lives that cleave spontaneously under normal body conditions. We want those without active metabolites. For example, the benzodiazepines have tremendous problems with active metabolites. They get excreted in the bile. They get reabsorbed again. So we get something called enterohepatic cycling of benzodiazepines. The metabolites of benzodiazepines are often more potent than the parent drugs themselves. Okay, you might absorb less, but they're also more active. And that's where all the benzodiazepines come from. They're all metabolites of the same thing. You've got diazepams at the top, and then you've got all the other things that you use to sedate you before you go to sleep at night, right? We want drugs that can be rapidly cleared. We want drugs that do not need special enzyme systems for breakdown, like succinylcholine, for example. We don't want those sort of things. We want very rapid onset and offset. We want drugs with an adjustable duration of activity. We can have drugs which can be reversed immediately when combined with a second agent. As I said, this guy is actually currently working on propofol and finding an antagonist for propofol. Drugs whose potency is so high that you need very few molecules. In fact, you want drugs that are extremely potent. You want drugs that are extremely immediately available intravenously, right? Why? Because less drugs means less molecules, means less side effects. All the drugs that are very nasty, ephedrine, succinylcholine, the worst drugs that you have when you open your drawer every morning, right? Those are the ones you want to get rid of. Why? Because they're usually low potency drugs. Now, you will not be able to achieve good anesthesia and also, unless you also have good equipment. And I don't mean just pumps. I mean hemodynamic monitoring. You really need, again, anesthetists are very lucky. We're in the era where there's minimally invasive agents, right, or machines that give you so much, information hemodynamically, and you don't require anything like Swan-Ganz lines. So we have the invasive ones, for example, for hemodynamics, the Swan-Ganz catheters, the PA catheters, PICO, LITCO, actually, that's LITCO, mixed venous oxygens, and so on. Then you have the minimally invasive, where all you require is an arterial line, the Vigileo, the EV100, 1000, I mean, the NextFin, the Clearview. And then we have the completely non-invasive, which unfortunately are not as accurate, perhaps, but again, in the ED, they're probably the best to go. So what I'm saying is in the intensive care units, we can use the invasives. In the ORs, we can use the minimally invasives. And in the frail, in the ED, for example, we can use the non-invasives. Now, this is something that has sat on my anesthesia machine now for 20 years, right? It's, this is the hemodynamic monitoring I call hemodynamic monitoring. This is the situation where you can measure cardiac index, cardiac output, beat by beat, stroke volume variation for every heartbeat, right? Where I measure systemic vascular resistance index, mixed venous oxygen. And this is a box like this which is attached to your arterial line, right? And takes minutes to set up, you know, and not expensive, you know, in the overall scheme of things, as I told you. Anesthesia is not an expensive service. The failure of anesthesia is a very expensive service, right? But not giving good anesthetics. So really, it's you know, I'll try and talk Prof. Juliana to buy you some good stuff. All right. Okay. Now I told you about these star drugs already, but remember that these are probably drugs that you want to use in the elderly and the frail elderly, which is where we started this morning, right? That these are the star drugs for the very frail. So, for example, a drug like remifentanil. When we first got remifentanil, we thought, how am I going to use this? You know, what use is it to me? This is a drug that 90 seconds after you stop an infusion for 6 weeks is not there anymore. It's gone. There is no such thing as remifentanil 90 seconds after you've stopped the infusion. Zero. And everybody said, oh, well, bad analgesia. You know, they all wake up, you know, feeling pain. Of course they wake up feeling pain. The drug is not there anymore. You know? So basically, when you look at something like this, right, it's the ultimate, to me, anesthesia, mu opioid receptor. Why? Because it rises very fast to steady state. It has no active metabolites. It's ultra high potency. It's 8 times the potency of alfentanil. It's excellent analgesia. It has no hangover at all. It's broken spontaneously by esterase cleavage, and there's plenty of esterases in your body. You don't need to go to the liver. Ultra short action and no target organ for metabolism. If you have no liver and you have no kidneys, both, right, you still metabolize this drug. You don't need anything. You don't even have to look up what the GFR is and what, you know, and so on. So it's one of the most brilliant anesthetic agents. But what are the downsides? But what, you know? And, well, you know, the potency, as I said, is very high. Great analgesic. It doesn't produce nausea and vomiting. It does produce chest wall rigidity, right? It does produce profound ventilation depression while you're giving it. But once it's gone, of course, you return to full respiratory function, right? And it can produce a mild bradycardia. Again, not usually a bad thing at induction of anesthesia, a mild bradycardia. So this is to me, just one beautiful pearl to be placed in the chain of all the other drugs that we use in anesthesia. No other drugs in anesthesia are as good as this, basically, in the opioid field, right? Now, for example, if you look at 65-year-olds plus presenting for surgery every day, right? You'll find that they're on an enormous number of drugs for peptic ulceration, antithrombotics, HMG, CoA reductase inhibitors, NSAIDs, beta blockers, vitamins, beta lactams, antibiotics and things, and penicillins, fluoroquinolones, ACE inhibitors, calcium channel. You know, every patient I see nowadays has, you know, everybody's swallowing 14 tablets a day just to make sure that they stay anticoagulated, but mildly so, etc., etc. Anesthesia has to take care of all of these guys with all of this rubbish on board, you know what I mean? And so what can we do for these people? Often, if they're very frail, best thing to do is to take them all away. They don't need them. Doesn't matter if they get cancer of the prostate in 10 years' time when you're 95, you know? Doesn't matter if you get a clot and you die if you're a vegetative state in a nursing home. This is all a lot of waste of money, basically, right? From a medical and health point of view. Again, for example, I looked at Maltese. I come from Malta originally, it's a little island, as I told you this morning. Look at, you know, senior citizens, right? So we're talking 65 plus. 36% of them have arthritis. 26% of them have diabetes. 17 smoke. 14% are blind or have very reduced visual acuity. 14% are deaf or have reduced visual hearing. And 12% need some sort of aids to help them in movement. So, you know, all patients are a bit like this, right? Again, in Sydney, for example, 65-year-old Maltese speakers. However, it's interesting, you know, that the good things are also there. For example, 97% of 65 pluses
are independent in all personal care, in bathing, feeding, and dressing. 96% are continent. 94% are cognitively intact. 90% are very mobile. 82% are independent in domestic care, cooking, housework, and so on. 76% live separate from their children, right, in their own homes. And, what is more interesting, 60% of 65 plus people provide support to others, whether it's their children, their grandchildren, other people around them, and so on. So really, it's not such a bad scenario. I showed you this morning, and this looks at now this group of people who are older and what anesthesia can do with regards to surgery, right? Again, we've seen the serious consequences before in the elderly patients, pain, which eventually produces morbidity and mortality. Now, if you talk of the analgesia package totally, multimodal analgesia, in fact, involves a number of things, right? It involves regional anesthesia techniques. It involves adding regional anesthesia to systemic type things. The analgesia itself has to be tailor-made. We start the analgesia before we even start surgery. We give intraoperative surgery. Intraoperatively, we give analgesia as well. So basically, now we're looking at total packages of things for each of our patients. If you look at the frail elderly, right? Again, they have a number of problems. One is, as I told you before, the preoperative polypharmacy. There's about 9.2 meds, right, per day given to 70 to 70-year-olds. And once they get to 95-year-olds, they receive 11.2 medications per day, right? Drug interactions. How do we know what these 11.2 medications are doing in terms of drug interactions? And then on top of that, we have to with analgesia and so on, right? Inappropriate drugs for comorbidity, right? What do we need to do? Well, first of all, we need to start learning to de-prescribe, to reduce it for them, right? Remember that most drugs in the frail elderly have very limited benefits. It's not the same as giving these drugs to 50-year-olds at all. So, the aims of ERAS and what you should call now ERAA, not just ERAS, so this is ERA anesthesia, right? Does deprive the frail elderly? Not always. And yet the rules are almost invariably local, regional analgesia, and finally major neuraxial blocks. Now let's take a sedation, for example. How would you do a sedation for an extremely frail patient, right? I tell you, sedation is one of the most dangerous things that you could ever do to an elderly patient. I'd rather do major cardiac surgery with full hemodynamic control on a frail patient, where I have control over absolutely everything, than to give them sedation. Why? Because it confuses them, because basically sedation is enough to produce cognitive damage to the very frail. Why? Because you have absolute no control over the hemodynamics, you have no control over respiration, right, when you're dealing with these patients. So sedation is out for the frail patients. The surgeon telling you, oh, quickly, I need to take off this one, and they're 95-year-olds. You say, yes, sir, but this one is frail or super frail. And you say, oh, all they need is a bit of sedation. Be very, very careful. That is one of the most dangerous things you can do to a frail person. Okay, but what I would do, for example, normally I would have used midazolam. I will now use remimazolam, which again is like I don't know, probably don't have remimazolam yet, but don't worry, it'll come, right? And fentanyl, I wouldn't use fentanyl or morphine for that matter. I would use remifentanil. I would use low target propofol infusions. Even something like sedation is a very dangerous thing in a frail patient. Now, remimazolam, I told you, that's the drug itself. Okay, it's called Bifavo, right? And it's an ultra short-acting benzodiazepine, very, very short-acting. Even if you have very severe hepatic or renal, even an ASA 5 easily. No, as you can see, but let's for pain, good. It's got severe hyper and flat. We start stuff and they measure the blood doing. You know, 40 stick, you know, running the equipment, right? These drugs being me, for example. Is drugs, okay. One which as so the in the doing business, right? Fancy do you want to that go sitting of you. Or poly, the every day. Don't get CJ post operatively. Let me tell you how that guy do this. elderly. And I'm very grateful for slides. So you can many of so it's down here. I mean, pay. So this is a level that you want. So the pink guys over here, right? Right? That's big stuff. To do unit of a local. Right? The dual. That's
Break to continue the we will continue enough well the question. Okay, please. Our second session.
A lot of material. It's easier. You still remember. Yeah, we're only perhaps about 8 of the euros and so on between and the GS. Some places even worse in Florida. If they it's preoccupation, which does then airway devices that you if I cover but all I complete this and let's of all we have the years ago reduction the same way, right? It's been for at least right a little, it is bad technique, right? Just as fail to intuit no start nitrous because it's relaxing. So that has worn off. Just this is the, we start with protect and not only about for everything else. Number of very off. Has of the but the drive and then do you have okay keepers way it's a you can use on this degree scenario and I increase again there's no hours you are but the thing it's your old formula this or even people 19 right anesthesia has got this scenario has on 2002 there's no point measuring right So what has changed? Well, there's a change of that we use. This is why some you will be out, right? So this numbers of people who come residents like here, like you, Chuck, you know, and I do it 13,700 in that Minister Oxford. The babies right? Patients. The note when come home. It's always quick, quick, quick. We have to fact now before you sequence. Developing the algorithm. Do you see every cesarean sections? Philosophy, but certainly might be the that operative cesarean section has now, you know, said the baby because the interpretation where if you give the stress, we don't on HRT stress. Oh, before right, freezing from whatever face well it doesn't right if it if the in spasm bling will auto to administer, you've got the drugs, you this is my own this rule of 100. Relaxing diapentos, right? Goes like right? Left or rock uranium and has changed the you cure the air analgesia of 100 sucks and the dosage, some caveats, for example, right? Necessarily, you know, that's right. To me, the important that you should be doing. This is much better than this one. We start here, the patient. You can always want to do. So once which you so on, cut. This is about start the procedure. Because you've got or all that you want to do, you know, just intubation. A long time. Okay, so this one is one slide that you want to observe. Okay. With probably more with ketamine time of in 1984. So again, final thiopentone. In terms of far, where and the for the much easier wrong to buck and cough and do. Okay. So a normal patient will agree that preoxygen and in apnea, right? Before the suction again, and you're all right, right? To ventilate, intubated, not able to ventilate. Because this adult, and it get this so interesting because this is the child. It's but then, which is why you shouldn't be doing the 7 cardiac anesthesia. Example, the of different things past, and now we use uh, is inducted with a mask. Uh, uh, high, right? You turn why do we want to use first of all the expense of the patient wiped out. Excellent it is. Cyclodextrin nice real oxide dextrin, right? Cells. Molecules coming out and molecules. Fluorine, SIBO, DES, and so on, right? Again, in the past, they also used to use nitrous oxide on its own. But what's the point? You might as well give them 100% oxygen instead of nitrous oxide and then add one of the other things, right? So basically, most for cesarean section, The nitrous was very bad because it produced awareness, right? And SIVO in oxygen or air, or oxygen ketamine opioid, for example, could be used for the maintenance in the cesarean section. And this is the one that was on the old system, 50-50 nitrous, oxygen and SIVO 2%, and then cut down the SIVO and give the syntocinon and go to a 70-30 oxygen nitrous. One thing that you need to keep in mind is that there are now a number of supraglottic airway devices that we can use instead of intubation. At this stage, they're mostly for rescue in situations where we can't intubate. But in some countries like Korea, they do their cesarean sections routinely with these devices. So this is something that's, you know, and the ones you want to use for patients in this situation is, first of all, LMAs like the ProSeal, supraglottic devices like the ProSeal, and also even better, if you need to intubate halfway through, you might want to use the fast track. So you might even use this device if you can't intubate by having, first of all, securing the airway with the fast track, and then putting an endotracheal tube down the fast track, right, to secure the airway. Again, so this is for me giving my Caesar, right? So this is now my failed intubation drill, right? And this is the other thing that has changed, that basically in the failed intubation drill, all of those things, oxygenate the surgeon, call for help, oxygenate the patient, call for help, and so on. But now, suddenly, the laryngeal masks, the supraglottic airway devices, the SADs, have now become part of that sequence. Now, pulmonary acid aspiration syndrome is a thing that you read about in books. I have some incredible 1970s pictures, for example, of horrendous damage caused by proton pump inhibitors, by pulmonary acid aspiration. Thanks to proton pump inhibitors, sodium citrate, antacids, H2 blockers, we have eliminated, but decent cricoid pressure, decent securing of the airway, this pulmonary acid aspiration syndrome. Remember that aspiration is a bad thing in obstetrics because it can happen in any instant and can change a life forever, right? The best protection that we know of, and this hasn't changed very much, 150 milligrams ranitidine times 2 pre-op, or 50 milligrams ranitidine intravenously for emergencies, plus sodium citrate, and this hasn't changed really. Cheap drugs, readily available. You can give them, if you can anticipate, you can give the ranitidine very early in the piece, and so on. I like to use what I like to call a belt and braces recipe for all my seasons. So I use a proton pump inhibitor, an H2 blocker, and an antacid. So the night before Caesar, I give them Nexium, esomeprazole. On the morning of surgery, I give them ranitidine, and on call to the OR is a standing order that everybody coming to the OR gets 30 mils of sodium citrate, and that's it. Okay? So this is the way to stop people aspirating. Very simple. You could probably use it for most surgeries, not just the Caesar. Now, with regards to the alternatives in airway techniques, are a number of things that we can do, right? We can do a wake fiber optic with oversapien airway, Macintosh laryngoscope, and a gum elastic bougie. So this is all the techniques you would use if your initial intubation failed. Retrograde wires, flexible fiber optic intubation, combi tubes, video laryngoscopy, which you've been shown yesterday, especially things like CMAX and so on. You know, many, right? But we do have a lot of airway tools that are new for the cesarean section, and they serve us well. So things are better in that the failed intubation protocol is now more secure. We have better alternatives in an emergency, but the answer is, do they serve us well? No, not really. A resounding no. We still need to use ultra short-acting muscle relaxants without succinylmetonium side effects. So until Sugammadex becomes freely available for all cesarean sections, so we still haven't got around to completely solving the full stomach with fetal distress, with a difficult airway and failure to intubate. You know, we haven't solved that problem entirely. So we'll have deaths in the future from things like that. How has monitoring in cesarean section altered? Well, first of all, we have oximetry, we have capnometry, we have routine neuromuscular function monitoring on all our machines. We don't have to even think about these things. We have things like bispectral indices, so we know how deep they are and so on, so entropy and so on. And we have the non-invasive hemodynamic monitoring, like NextFit and Vigileo and the EV1000. So basically, the obstetric GA Caesar scenario is very much safer than it was when I was a baby. The other thing that we have to think about is the baby themselves. You know, how does this alter the likelihood that the baby is not damaged in this whole procedure, right? What do we do about the baby? Well, you know, we can actually measure things in the baby. We can do fetal scalp pHs, we can do fetal heart rate presence, Dopplers, PNADs, fetal oxygen saturations, and so on. So we often know, unlike what used to happen 50 years ago, what the baby's doing through all this journey. We can measure it all the time, easily. Why? I said that one of the other changes, apart from philosophy and drugs and techniques, is the theoretical reasons, right? A, we're looking all the time for, we're talking about the baby now, not about mum, huh? Is we're always looking for new agents, right? We're always looking for better agents with minimal effect on the newborn. And the ketamine propofol combination, to my mind, produces better neurobehavioral scores outcomes in the babies. We have a better definition for the need for urgency. Most of the old urgent Caesars are not urgent Caesars anymore. They're almost urgent Caesars, and they have to be done now, right? So we now describe a fast or a slow rapid sequence. The rapidity of the techniques and the application of cricoid pressure may actually make it more difficult to intubate, for example. So if you have cricoid pressure on in obstetrics, it might be more difficult to intubate that mother. So really, we need to look carefully as to whether we should release cricoid pressure in situations where you can't intubate. Now, changes to the GA Caesar, which are related to maternal comorbidity. And this, again, remember, we're talking about baby mainly here, right? So, mothers, for example, muscle relaxants, there are problems with people who have muscular dystrophy, for example, in the mother, right? Inhalation inductions, amphetamine intoxicated patients that have no venous access, for example. How do you manage these with inhalation agents instead of using intravenous agents? Fentanyl, alfentanil, fentanyl droperidol mix, right? In severe preeclampsia instead of using ketamine. Remifentanil tiva and propofol TCI in very large, in patients who are themselves, the mothers are themselves very severely, or for example, if the baby has, for example, a tumor in utero, what is known as the exit procedure, how do you manage these ones? And these are very special cases for anesthesia, and I don't want to go in there today, but all of them are very interesting. So it's one of those situations, you know, you have your little caravan on the top of the poles over there, and everyone says, this can't be done, right? In rapid sequence induction, it's been a bit like this. Everybody thought it was impossible to change that sequence. You know, it's like, what do you do? You know, why? You know, how do you manage these patients, right? Well, you know, the failed intubation protocol has been changed. It seems impossible that anything else needs to change now, but it will change, and even my own sequence will change eventually. Remember that in Africa they have the Basuto have a proverb which says, if a man does away with his traditional way of living and throws away his good customs, very important in Bali, he had better first make certain that he's something of value to replace this with. So change your customs, change as much as you want to, but you have to have something better to allow you to do so. Don't remove your lovely buildings to build rubbish pieces of concrete, you know, that sort of thing. But also in cesarean sections is very much the same. You know, it's that sort of philosophical change. I think it's a very nice. Now, as I said, Gatt, I don't know if you know what Gatt means, but in Europe it means the General Agreement on Tariffs and Trade. Right? So here's Bill Clinton, right, saying Gatt is off the rails. And that's true. I am off the rails. I have been for a long time. But remember that Gatt's rule of the hundreds, 100, 100, 100, 100, and the rule of 35 seconds between each of the procedures is a good way, or a reason. So is there a difference between the old one and the new one? Well, you'd say yes, there is a big difference between the old system and the new system, right? We're really talking about something that is completely, spot the difference, it's not going to be too difficult, right? So if you compare the new Gatt's rule of hundreds, RSI, with the old thiopentone saxhalothane RSI, I'd say, you know, very different. I showed you this drug before with the elderly, right? Remember that the value of rocuronium is greatest when you have Sugamadex as well. Entree, madam. So, it's in 2006, I said so many modifications to the old GA Caesars have been put in place that when the modern GA Caesar is reviewed in its entirety, it would seem that the time has come to question if the standard GA Caesar is still valid and whether it is due for a major revamp. That was in 2006. You can imagine how I feel 15 years later, right? Everything has changed. So I think that the old GA Caesar sequence is going the way of the dodo. You know, what do the dodo have? They're extinct. I mean, you know, they're both extinct. The old GA Caesar sequence is extinct, gone, finished, no more, right? And I think we've replaced it with something very nice in the end. You know, we haven't just done it. And to me, Sugamadex was the last nail in the coffin, you know, because we did want to get rid of Sux mightily for 50 years. And I think we've achieved it. I think succinylcholine will eventually be seen as a drug that you see in the museum. Look what these guys used to use, you know, dangerous stuff, you know, in the museum. Okay. I promised that I would try and finish the sequence by 12 noon. It's now 2 minutes to 12 noon, right? And so in the interest of keeping the meeting on track and on time, right, I think that I want to end up with a few small things, right? There's a great difference between an elective Caesar done under general anesthesia and a great deal of difference between the elective Caesar done under some sort of combined spinal epidural spinal, whatever, right? The emergency Caesar, though, is a different ballgame, first of all, right? Especially when the emergency Caesar is preceded by a large number of other things, like augmentation of labor, a prolonged labor, you know, in somebody who's having a VBAC, that's a vaginal birth after a previous cesarean section. The drugs that we use are now very different. Some have severe pain, some don't have severe pain. Again, it depends on whether the emergency is a Cat 1, which means very urgent, or a Cat 2 or lower. But to me, I think that the GA Caesar will always have a special place, in spite of all of us feeling that in developed countries with highly developed hospitals, right, the regional anesthesia technique is by far safer. In countries that might not have as much control over things like sterility, for example, right? The ability, for example, to buy spinal needles and throw them away. I used to send boxes to Mother Teresa in Calcutta of spinal needles. So they would write to me 10 years later and say, Dr. Gatt, can we have another box? I said, for what? Because all our needles are blunted. These are disposable needles we use hundreds of times to the point where they become blunt, right? I mean, that's, in those places, the GA Caesar might still have a space. Professor Van Zundert is currently doing some interesting stuff in Mexico. Andre, do you want to tell them what's happening in Mexico currently?
It's a very tragic situation in Mexico at the moment. So the Mexican Society of Anesthesiology contacted me because I was involved for many, many years on safety issues in obstetric anesthesia. So I gave a lecture in yeah. Yeah, it's an 1100 page English textbook. It's an amazing textbook of pain relief and anesthesia in obstetrics. And yeah, it's very difficult to tell about myself, but anyway, a long time ago I started finding a solution. What is now an ideal test dose in obstetrics? Not only in obstetrics, but in all regional anesthesia techniques. And my formula that I designed is 0.125% of bupivacaine, to which is added 1 in 800,000 epinephrine. And if I'm coming to that. So if you give 10 milliliters of that, that's no more than 12.5 milligrams of bupivacaine and no more than 12.5 micrograms of epinephrine. And you can find out whether that dose is in the epidural space, in the spinal space, intravenous space, or even the subcutaneous space. Wherever you inject that, never give more than that dose. That is safety. So I ended up with a lot of publications, some 150 publications on improvements in obstetrics. And that's why the Mexican Society of Anesthesiology came to me and say, okay, you've done a lot on safety. Now we have a serious problem. Infection due to spinal anesthesia in cesarean section. So out of 1,800 patients who received the spinal anesthetic, not only for obstetrics, but for surgery as well, some 100 and plus patients got infected, and out of them 36 women died after a spinal for cesarean section. Of infections, They did not die immediately. It took a couple of weeks because it seems to be that it was contaminated drugs that they were injecting. I do not understand all the procedures as yet. We had this morning, again, a meeting via Zoom with the United States, the CDC, and several officers in Mexico. And most probably it is the morphine added to the spinal anesthetic that has been contaminated. Contaminated with a fungus, Fusidarum, a fungus, and we really don't know at this particular moment where exactly does it come from. So we have to do lots of things. So I've proposed at least 50 questions that needs to be investigated now. It's a very serious thing. Even the health minister has been sacked in Mexico. 4 hospitals have been closed. The directors of these hospitals, these are 4 private hospitals, not as big as this hospital, for instance, but private hospitals, and they have to, there are arrest warrants. So anesthetists have been jailed. They have been accused of murder.
And think about it where it is. It's in Mexico, which is one of the great channels of narcotics and opioids, and it's morphine. So God knows what the quality of the stuff is. God knows what, So that's the message I want to bring to you is that regional anesthesia is very safe in the right hands, at the right time, in the right places. But it might not be as safe as where everything you have in your hands, you can check yourself. And that's general anesthesia. Okay, so what I'm saying is, why somebody would say, why does Timor use a lot of GA Caesars? Well, perhaps that's the right thing to do. That's what they're trained in. That's what they do best. So so I intend to give this lecture for a great many years into the future, probably 20 or 30 or 40 years in my case, right? Why? Because I think GA Caesar does have a place still everywhere. Now, when it comes to analgesia, paracetamol is one that's very good for after GA Caesar, 20 years experience. There are very few contraindications to using intravenous paracetamol, proven by experience to be side effects are very rare, very cheap. But there are not very many studies, mind you. Again, NSAIDs and COX-2 inhibitors, remember the possibilities of for example, COX-2s opening the patent ductus and leaving the patent ductus open, ductus arteriosus in the baby. So again, we need to be careful, but it's a rare thing. This is a small print at the bottom of, compared to Mexico, this is very small print at the bottom of. So, you know, for example, NSAIDs and COX-2s are not approved in breastfeeding women, technically, right? But nobody's done any studies really, but this is just theoretical. So the answer is we use them. Diclofenac, ibuprofen, right, are used everywhere in the world off-label, really, because there are not a lot of studies of diclofenac and ibuprofen for post-cesarean section pain. Again, the closure of the ductus issue, right? Once the infant is delivered, really, there's very little risk and sometimes much benefit from closure of ductus arteriosus. So closing early is not such a bad thing, you know what I mean? Again, intravenous paracetamol, right? And following on, for example, with oral valdecoxib or rectal ibuprofen or diclofenac or rectal or oral paracetamol makes to me very much good sense. These mums don't need huge amounts of narcotics. And in our situation, these mothers don't seem to have the normal pain that people have. You know, I brought with me no, there was something called sorry? You know, people talk about ERACs. This is the Royal Hospital for Women, and this is what the Royal Hospital for Women, since my children were born 40 years ago, right? Our patients don't go to hospital, have a Caesar, and then go home. Where do they go? They go to a hotel, down the road, on the beach, beautiful place. They've got oxygen in the walls. The lactation consultants come and see the mothers. It is absolutely doable in Bali. You can choose any hotel you want to. You don't spend a lot of money. You know, they have a good time. The government allows them 4 days of insurance cover, basically, on Medicare. So we use the 1 day in hospital and 3 days in so ARAX is a piece of nonsense in my scenario, right? You come in for a Caesar elective, you come in the morning, you go down to Coogee Bay, to the beach in the evening, or perhaps the next morning if it's an afternoon. The antenatal care, we have a history at the Royal of having done antenatal care for 170 years. You know, we celebrated our 50 years of epidurals, continuous epidural service for labor and delivery, 60 years now, you know what I mean? We're celebrating 60 years of continuous 7 days a week, 24 hours a day, epidural service. Right? So what I'm saying is, a lot of the things that other people are still struggling with achieving, we've been there 50 years ago, you know what I mean? I put up the first obstetric intensive care in the world, right? Known as the acute care center, right? With ability to ventilate patients, do all those things, dialyze them and so on, right? 35 years ago, right? Some people don't have obstetric intensive cares. There were no obstetric intensive care units anywhere in the world that are dedicated purely to obstetrics. And yet it was doable a long time ago, and it's easy. If you're an obstetric intensivist, that's all you need really, a bunch of obstetric intensivists. And it's a really pleasant job, if you think about it. So what I'm saying is, you know, again, you know, this is celecoxib, for example. At one stage, much ado were done about Vioxx and so on, right? And the potential for people getting more strokes and so on. In obstetrics, these things don't apply at all, you know what I mean? So if you want to use celecoxib, God bless you, right? COX-2 and breastfeeding, again, the amount of COX-2 in the breast milk is low. The absolute infant dose is tiny. It's 9.8 micrograms per kilogram per dose. And the relative infant dose is 0.3%. So really, don't worry about these sort of papers appearing, they mean nothing. COX-2 inhibitors, they reduce the potential risk of bleeding, tocolytics and COX-2, reduced effect on uterine relaxation compared to non-selective stuff like ketorolac, right? Rectal indomethacin, again, okay, 100% reduction is not huge in post-operative cesarean section analgesia. It goes from 100% down to 72%. But what I'm saying is all of these things put together make very good analgesia post-operatively if you want to go down to the hotel. Okay? I've been using these drugs routinely for, as I said, 20, 30 years now, right? And I tell you, some of these things are absolutely, used together, are absolutely magic in that. Now, I think we're coming to the end here. In fact, that thing I was going to show you before, hang on, give me a second. Okay, these are our post-operative cesarean section schedules for the recovery room, right? The first one is morphine, that one there. This one is fentanyl. This is betadine, right? And that is tramadol. So, and the background infusions that we have to use and so on, in the recovery room. So, so I think we're coming to the end of this. So post-operative analgesia following cesarean section, large number of things we can use, right? So thank you, friends, for listening to my memories. Terima kasih atas perhatian Anda.
Okay, thank you, Professor Stephen Gatt. Okay, now we are entering the Q&A answer. As we know that we already have 2 topics for today. Is there any question regarding the first and the second topic? The audience may ask the question and raise their hand. We will handle the mic so you can ask the question. We will open for the first 3. Yes, please.
This is the best one they've got.
Thank you for the opportunity to ask the question. My name is Kevin, doctor, and I want to ask about, is there a specific situation which you will use this Gatt 100 rule? What about in situations like eclampsia? Would you use it because there's the risk of hypertension? And ketamine, which you use, I think, I don't know about the average weight of the woman that you give this drug to. What about the risk of a hypertonic uterus? And in case of
it's very. I think this is a very good question, really, because has always been a big worry with preeclamptic patients or other patients with hypertensive disorders of pregnancy. I think it's an important question because there are some patients who don't have hypertensive disorder of pregnancy, but who with ketamine will get a high. And this is why I think ketamine on its own is not a great drug to use on its own, right? In our situation, you remember that we're going to give propofol, very quickly afterwards, within 35 to 70 seconds, you're going to have some propofol as well. So one is going to raise your blood pressure, the other one is going to drop it. So in the normal sequence, you won't see any changes. The question is, should you give ketamine to any hypertensive woman unless you've already controlled the blood pressure? And in preeclampsia nowadays, of course, the control of blood pressure becomes very, very important. Now, what you use has always been a very contentious issue because in the past, right, the Americans never used things like, they'd use beta blockers, they'd use calcium channel blockers, they'd use all those sort of things, but they would never use magnesium. In our hands, we use magnesium very aggressively nowadays. And there's some very interesting papers in the Lancet written about 35 years ago, which says everywhere else in the world, magnesium is used as a laxative, right? To get you to go to the toilet, right? We don't realize that it's actually a very, very good drug in the treatment of things like eclampsia, right? Why does magnesium work so well? As an intensivist, I now have had about 15 patients who had hyperemesis gravidarum, where they vomit and vomit and vomit and vomit for the whole first trimester. And I used to bring them, some of them had to come to intensive care to receive TPN because the babies were not thriving from this repeated, continuous daily vomiting. Initially, I used to start them on TPN, and within 2 days, it was gone. Even the vomiting was gone. And I always wondered what it was in there. And eventually, I started treating them with, I've never written up a paper on this, but I've got this love for magnesium, for hyperemesis gravidarum. And I now have developed a great love for magnesium in treating preeclamptics. I can give you a whole other one of these 2-hour jobs on preeclampsia, I can tell you. But all I will say is, if your hypertension is controlled, if the magnesium infusion is running, right, then I would use ketamine, right? But again, this is all to do with intensive care judgment, right? I can't tell you to do this to everybody, because I'm sure it'll be misinterpreted as to what I'm saying. But if the hypertension is controlled, if they've been running magnesium infusion for a couple of days, absolutely no problem. What would you use instead of thiopentone, instead of ketamine? What I would use is I'd use propofol, for example, right, instead, or use a ketamine propofol combination for that first early induction bit. You still have to give some more propofol later on, because by then the levels have started to fall. Okay, but very good question. I think that's very useful here. Anybody else? Anybody brave enough to question me? Okay. We've always got that last one at the last moment, but she's a leader, see so.
Thank you, Prof. Gatt. Talking about ERAS and frailty, we often use regional anesthesia here for the patients, especially for orthopedic patients. I want to ask if you, how about your experience if you have geriatric patients with the orthopedic surgery? We know that patients for the geriatric have a lot of problems, hypothermia, and risk of like severing intraoperatively. Sometimes we give the pre-medications like ondansetrons, and sometimes maybe out of records we use petidine. What do you think about petidine? It is safe because petidine is on the list of the criteria that can cause POCD in the patients is the first questions. And the second, for the patients, acute pain in the geriatric patients, the first line is opioids. If it's in the settings on the wards and we don't look after the patients just pre-operative, not look for the patients regularly. It's wise to use opioid for the first, for the analgesics, or because paracetamol is not enough for the patients. What do you think?
Irene, thank you for the question. I say thank you because this is a topic that is so broad that it produced controversy for 20 years. First of all, the issue of what is the best technique to use in anesthesia for these elderly patients? Was GA safer than regional? Was regional better? You know, and as you know, that argument went on for many, many years, with hundreds of papers written about, one group saying GA safer, the other saying that spinals and epidurals and so on safer. With these patients, you'll have to admit that whatever, you know, damned if you do and damned if you don't. You know, it's between a rock and a hard place, you know what I mean? There's always going to be a high mortality, a high morbidity, and so on. What I was trying to convince you today is that the solution is not using opioids post-operatively, but using opioids sparingly post-operatively by combining. Paracetamol is not enough, I agree. You know, paracetamol and ibuprofen together are not enough, I agree. Morphine and a COX-2, for example, not enough post-anal. But if you use them together, especially, for example, if you leave the epidural running at low dose, right, at the same time as you're trying to do these other things, you can get away with a lot without causing always try to use the minimum amount of drug, but not one drug, a number of drugs, whole barrages of drugs. You know, for example, for us with abdominal surgery, the pain buster soakers have been fantastic. You know, you've eliminated not the internal visceral pain, but you've eliminated all the cutaneous pain, which in elderly people is probably more important than the visceral pain that they have inside. And I think I've spent that whole lecture trying to convince you that there is no one magic formula, but combination anesthesia, especially combination of regional with GA, combinations of inhalation agents with intravenous paracetamol, paracoxib, all those sort of things intraoperatively, is the way to go, right? So if I had to tell you, you know, what is the best technique to use, I don't know. You know, we all do broken hips all day, every day, you know, in the orthopedic theaters. Most anesthetists have their own little box of tricks, you know what I mean, little boxes of magic. Some are better than others, you know, at doing it. What you must look at in the elderly is whether anesthesia responsibilities end once the surgery is finished. And I argue with you that until they leave hospital, anesthesia should always be involved in those patients, which is why we have very many elderly now anesthetists who probably would have retired otherwise, who walk around the hospital after surgery and walk and see each of these patients. They're not necessarily on the acute pain service, because the acute pain service also comes to visit them every day to see if the levels of analgesia. So that's why I brought in that bit about administration. The way you organize your department is very important. This is not a job for one person who gave the anesthetic. One guy gives the anesthetic, but the acute pain services comes in afterwards. And then come the clipboard guys and girls, you know, who come and check that the pain relief is good. And what are you receiving now? And how can we adjust it for you? And when can you get out of bed? As soon as possible, always, you know, with everything. The amount of time they spend in bed nowadays, these elderly patients, is very short. They're out of the bed, always on a chair. Gone are the days when they lie there, you know, for days, doing absolutely nothing, and then get the pulmonary emboli, and then get the infections, and then get, you know, all those things. No, the management of the elderly has to change very dramatically. From what I've told you today, the management of obstetrics might want to change very dramatically as well, but anyway. Anybody else? Or are you all too hungry?
Okay, maybe that's for the Q&A for the first and the second topics. Now we will continue to the lunch break, Professor.
Shall we have lunch in the middle or not yet?
Yes, now we will have lunch break, and
Yes.
we will gather here again and at 1:15 to start our third topics. So we have like 45 minutes for lunch.
Half an hour, how about that? So you're home, so you get home early. Yes, 45 minutes or half an hour? What is the consensus?
Jam 1. Okay, change the time. We will gather here again at 1 p.m. after the lunch. For Professor Gatt and Professor, we have prepared the lunch buffet. Please enjoy the lunch.
Thank you very much.
Yes.
Well done, man.
Buat para peserta, Nanti sekitar 15 menit lagi boleh menuju Balai Bengong buat lunch setelah profesornya selesai.
Go for your lunch.
This is the stuff with all the segment.
Oh, okay.
And I'm not quite sure what he wants us to do with it, right?
Oh, yeah, just
No, we
few questions.
call facilitators, right? And there's just those 4 questions. Okay, that's fine.
You've seen the question,
This
5
is
questions.
very
You've
much
seen-
my game anyway, so.
Yeah,
Yes,
yeah,
but I've got
that's
the
the reason I proposed you, because
Yes.
he asked me, but you're much better than that.
From tomorrow, maybe at 9, maybe I think. Is it okay?
Yeah, that's fine.
Because when we will show in the screen. Because I heard from the registrar, a lot of them need to have students. Yes.
I'll be tomorrow ultrasound Teresa anesthesia. I will be at 8:30 here because I need to check
Oh yeah, yes.
the model first.
Oh, that's
Otherwise, I
right,
don't
that's
know
right.
the anatomy of the model.
Oh yeah.
Yeah. 8:30. Yeah. And the people will come in at 9. So the audience will come in at 9. Is that okay? So I'll do at 8:30. I'll do the scanning, or I'll do it maybe at 2 o'clock. If I do it at 2 o'clock, we can start at 8:30. And you have the ultrasound machine available at 2 o'clock, huh? So, yeah. Okay, I'll do that. Can you find a room for me with the stretcher? Yeah. Okay, good.
You just organize.
Yeah. And then we'll start at 8:30. Okay then. Thank you.
Maybe I didn't realize they made you chief, not just leader.
Not too early.
No. I'm early. I'm awake at 4 o'clock.
Oh. So how long you will be? 2 hours or 3 hours? It's enough.
Depends on how it depends on their level, their level of anatomy, etc. So if the level is high, I can go faster. If the level is not so high, then I can.
So after probably another college maybe want to hear again. So maybe another college.
You mentioned to me recently. I was joking about that. No, I'm not joking. I'm involved with Timor-Leste.
Another college outside of
No. But they are putting in
You want me to give another call?
it's together then. I mean, not only maybe because tomorrow
I've been asked
it's
if I could have a live
you want to meet what
Are they doing it ultrasound?
copy for a block and also say thanks for it. Oh, Prof, this is Gado-Gado, Prof. Okay, Prof.
I wouldn't mind a cup of tea actually. So basically, we need two things, basically, right? We need first of all the light. It's for medical students, so it has to be not just chemistry. I'm arguing that my entire life. I've also got a friend who is given me a limited number of computers. They have no place. I said, how many is it? More than 600 or something? Less than 600. I don't know. I know it's organized by the local institution. So it might have applications to your life as well, you know, if you end up remaining the one person forever. It's not a good thing. If you can really get lecture every now and then. Or 14 more individuals. But anyway, for example, this computers business, this guy was telling me that he used to have a business, a number of government departments, medicine, the hospitals, all the computers are from this one guy, and he had a contract, and broke down, but the new one and lost the contract. So the company brings in all these very high quality computers, right? Destroys the hard disks. They first wind up using 3 different companies, software. And then the hard disks themselves are chopped into pieces worth like 2 millimeters by 2 millimeters. They all mix together and then they melt it, and that's how the whole instance data don't get destroyed. At the end of this ends up in computers. So all they need is hard disks, very hard disks now. People don't want to see the hard disks. All those very computers, software, whatever, guys require,
So that book. There's one there and another one there. Right? This is a book which was written specifically for Malaysia, Indonesia, Singapore, that sort of stuff. And the three authors are Alexia, Singapore, White and China, Malaysia, and myself. It's very practical for use by local people. It was never meant to be a big textbook. I've got one copy there, one copy there. One was going to be your copy, one was going to be your copy. But anyway, I decided to give it to you. Now the other one is interesting. These are stickers. Like you open this sticker. Let's go over to the anesthesia shop. How many do you use the codes on themselves? It says loose, or it says cracked, or it says, because that way, when after doctors say, so don't try to sue you because you've broken their teeth, you say, hang on, this is going to work. Identification is starting, it's not there yet, but it's starting. I haven't even finished my soup. I haven't finished my back, sorry. You'll get some lesson. You'll get some lesson. I was really talking.
So these are the 5 questions I received.
I received 4, but anyway, sorry.
Let's see some yesterday's answer.
But what, you know,
I'm not sure. I'm not sure. It's 6 hours, I don't know.
exactly.
So I'm not sure whether, you know, I want to know his anatomy.
Oh, okay.
Yeah, so whatever procedure.
Okay, whatever.
Tomorrow it will be a high-end machine. Okay, good. No, I do understand. Let's go for the lower quality today and tomorrow the better quality. Okay, thank you. Just tell me when it's ready. You know, I have live models. I need to have live models. They are in use and operating periods. I cannot use them before 2 o'clock. Now, John Hamilton reminded me on Monday that I need to submit this. So now it's increasing size. Yes, this one is increasing in size. Still working on it, but it needs to be 59 minimum now. So I've added on a few more things. I will work on this tonight. And send it off to you.
I wondered if I should be working on this one now. We put it Thursday in the summer.
Yeah.
It's going to time, but what I'm trying to do is, I might offer, let me see, what I have in quality. Also have patient safety. See if I can combine them with 3 short bits.
Did you have any lectures with you? Take one of them. Well, I think that will help.
If I divide them into 3 different things, one is the patient safety, and the bits about the pilots and that sort of stuff, which I'm going to give some.
Did you ever meet Paul? Did you ever meet Paul in person? I don't think so. What? Paul Byron?
First, we worked at the University of and there was problems.
Yeah, I know. We don't.
Well, I don't know what the problem is.
I don't know.
Paul Byron is one of those people all over the world.
Then you have to Paul Byron.
There's a one.
On the right, just
This is
the one who worked in New South Wales. Even I was checking this all over again, and I think I need to move this one. This one, blue one. It's about the symmetry. And I think nasogastric tube should just be gastric tube. It's not nasogastric tube. Or do we call all the gastric tube nasogastric tube?
No.
So I think it's better to have
Gastric tube.
gastric
Gastric
tube.
tube or gastric vent or whatever.
Yeah. No, but I mean the catheter.
No, I understand.
So what is the name of
We're
the?
talking about gastric vent.
Yeah, but how do you call the gastric catheter? Gastric tube? Or is that the channel? Is that the?
It actually has a, as I said, it's either a vent or a channel or a
Yeah, but that's.
port or,
Yeah, but
but gastric only, nasal.
nasal should be out, isn't it?
Nasal to you.
But I mean, you have the channel of the device, and then you have the tube itself.
That's the catheter.
That's the catheter. So how do we abbreviate the catheter? Gastric tube.
The catheter has always been NGT.
Yeah. That's what I put down here as well. Nasogastric tube and NGT. But that's,
You know what I mean?
NGT,
Leave it as gastric tube. And then
the abbreviation.
And the bottom, I would put the as abbreviation the NGT over here.
Because I put down here, nasogastric. What should I do? Take the
I
N
would,
out?
no, I wouldn't take it out. I would leave the NGT there. And up here, I would put gastric tube, NGT. Right? And then over here, standard nasogastric tube. It's going to be used for it. Is what I'm telling you. But over here, put gastric tube.
Yeah. Because we're not using the
We're not
nose
using
at
it.
all.
No, we are exactly. We're not using it the nose at all. Otherwise, the tube itself is known as an nasogastric.
So that's the right name. Nobody made a comment about this. So that's good. But now, so don't do anything of this before I send you the next one. But the other one, did you do that? The one for the centennial.
You tell me when, what the priorities are. At this stage, the centennial meeting is coming up.
It needs to be in. We have another 4 weeks. That's it. But I still want to send it to Jadid and to Caroline. This one, we only do that ourselves.
No, I think I've printed this and brought it with us. So, no, this is not the one. Have you got the other one?
I'm not sure whether I have it here. I
Doesn't
don't have it here, but I have it in my room.
Exactly. In the case, give it to me over the next 24 hours. And that's what I want to be sure to do it with a pen and a couple of markers.
Okay. Now, my version is not printed with double space, so maybe it would be easier for me.
It's easier with me. But we don't have access to printing one. I mean, that's why.
No, I can ask them to print it here.
Okay, good. Go ahead.
I will ask them to print it here. Okay, I'll work on this one. Print it out.
We don't make you improve this one very much. I like this paper. I really like this paper.
Yeah, but there's a lot of comments. I've answered all the comments.
Let's do the executive. See, right? Or no?
Okay, I can understand this is new. And
I agree. Scoring systems are scoring systems. Maybe, yeah, not on the other.
But I have here that I can't use it because that's part of another. So this is the mannequin set, where we check the protectors, the safe element, and the saco. But this is a mannequin. This is a mannequin set, and I cannot use the same results. That I can't do.
But you don't need results.
No, I said, one of the comments was, we have already submitted this for publication. So we don't need a scoring system anymore. But that's not correct. It has not been submitted in the writing phase. And so I put it down here, not yet submitted for publication. Yeah, it's not Anyway, I really addressed all the issues that are raised with the British Journal of Anesthesia. And the dawn things, and I hope you will like it. Okay, but I'll give that tomorrow. The main important thing is the other one, because that is what we and I cannot say we only have 1 week to give it
Hi, Professor. I'm Cindy. I'm the one that's supposed to be informed by the Priscilla Chandra.
Yes.
Yeah. Hello. Nice to meet you.
Hello, hi, Cindy.
Cindy. Hi.
We met yesterday, of course.
Do you watch radio?
Yes, I am. I'm sorry I just met you because we have patients, so I have to deal with this.
I know. You work a lot in intensive care, isn't it?
Yes, my background is intensive care, but that's why. But we do also the other things. So
I'm exactly like you. Because I'm actually both intensive care trained and anesthesia.
oh, correct.
And medical administration. And service management.
I've seen that you brought some beer
No,
now.
no beard, that's not the beard. No, the beard is here, right?
Oh, sorry.
It's gone. It's a big side beard.
Because the last time I saw you, you're not like this.
Right,
Okay, so I guess maybe this is the pandemic style. I don't know.
That's good.
But it's good.
It's like a disease. At least it doesn't itch. You know, all the other guys are always going.
Oh,
It's very itchy.
but it's good.
It's
It suits
a
you.
long
It
beard.
suits you. It suits you.
It's good. You like it.
So how about?
Geez, I like your vest. Your shirt.
It's a local brand. Thank you.
Yeah. Local brand.
Yes, actually I wore this because we had rain today,
Yes, I saw.
so that's why I put on. But then it's getting humid, so I'm a little bit I'm sorry about it because now it's getting hot. But maybe we will have a little bit rainy in the afternoon, and then so that's why I put some. Yeah, that's why. So how about your lunch? You have lunch?
That's good. I'm not much into gado-gado. I don't like peanuts. Well, I like peanuts very much. I eat peanuts. But no, I like peanuts. I just don't like them as peanut sauce.
Oh, I see. So it might be a little bit different style of peanuts. How about your wife?
She's good. Yeah, she's actually at next to the beach.
Oh, really? Okay.
There was also a
I hope you still remember that she's here with her husband and not doing something else. I really hope so, right? Because maybe after quite some cocktails and then looking at the beach and
well, it was good for the coaches to put together.
goes both ways. Enjoy your meal, Professor, and I really. Okay.
So I'm impressed how good the English is. Nowadays, everybody asks questions.
I think it's because of the technology nowadays. You have many social media, so now you get a lot of information. So
We are forced to read English anyway.
yes, it's
And
everywhere.
that's good. That's
So
good.
that's right.
We need a common language. Communication is the base of a human being.
Actually, I'm interested in Flemish. Actually, the Flemish is very hard. Maybe the dialect.
I
Maybe
think
the
Bahasa
dialect.
is very easy.
Correct. We have no tenses. We have no past, present, future. We just say it with the subject verb. That's all. You have
Well, I can't explain it.
But correct me if I'm wrong, but Flemish is one of the most difficult.
That's what they tell me.
Yeah, maybe with the dialect. Or
I
maybe
speak Maltese.
you're a polyglot as well.
Polyglot. Poor French. Reasonable Italian. Very
Pronto, pronto. That's all. No, it's not a bit of English.
I wish I had the knowledge of this English. Yeah?
Yeah.
I only have 10% of it.
Once you do something like that, you start English.
Yes.
But you haven't done it for the last the first 5 years. You get after that, something goes up.
Correct.
It becomes very, very good. And Maltese is an interesting language because Maltese had no grammar until, say, 80 years ago. It was a spoken language. Everybody spoke Maltese. You know, no European, whichever way it was, like, and then came the so-called art of Armada, and it was the society of the Maltese language. And they started to make the rules. The Maltese language, absolutely perfect grammar. You say you have
say, I always know this place.
Really?
It's made, there are only I don't say Rawa, R-A-W-A, so there is R-A-W. Consonant, vowel, consonant, vowel, consonant. I always know how to translate that. It's always got what's known as the root, the roots, this is the roots. I love you.
What would you recommend us to see in Malta? Yeah.
It's the most incredible songs. But what I'm saying is, these are the countries that have so much stuff to show you every day. This is going to beaches, this is going to churches, everything is crammed into a space so small. Right?
You mean the Perth or more?
No, I'm talking about Malta. Malta, for example, has 400 churches.
Correct.
An island that's
So small?
17 miles long and 100 kilometers. These 400 are all in there together. And then there's megalithic temples and there's Neolithic temples.
How could it be so expensive?
It's a small place. Well, it's been added for a long time. It's banging in the middle of the Mediterranean. It's, you own Malta. It's a small place. You can't do babies. All you can do is live with them.
Which one is better, Malta or Macedonia? You know Macedonia, right?
Probably
Or maybe
This Palma de Mallorca.
yeah.
Madeira.
Yeah.
Oh,
Really?
well, first of all,
Okay.
secondly, they've been under the British.
They're being biased in this way.
Then before that, they were governed by a group of knights from Portugal, Spain, France, the whole lot. So basically, they were very international figure. But these guys only came as a religious order. They didn't get married. They were all monks. And so these guys just local population. They were never slaves. They were not slaves. They were just local population.
Actually, we did.
Yes, there is for you. I obviously have it already, but I printed 2 copies, that's all.
I see that you're lecturing as well.
Yeah, but he's the speakers. I mean, he's called us speakers here, speakers here, speakers here.
Yeah. But then we have the
This is the guest week.
roof presentation.
No, for example, RCA, you need to bring a whole this number of props for doing RCA, the cards and the flips. Sure.
I'm not sure whether they will bring those.
Nice. Okay. Do you want something else to drink?
No, water is fine. I finished already.
Yeah, I'll do it.
Do you know Bang Bang Tutok?
Very good, very good.
Who's that?
A friend of Dr. Cecilia.
He resembles much over here.
Yes.
Short guy.
Short stature, with glasses,
Round face.
nice hair.
Nice haircut, yeah.
That's good.
Okay, I know
But I
him
don't,
personally.
no, but I don't know if he knows about this topic. We need to label with these.
Actually, he's more into ethical problems.
Exactly.
The ex-president of that's why he's more into ethical problems. And also the reversal of masculine values.
Since he's
Yeah, correct. Somebody.
This is such a good.
he's trying to achieve, he's as lecturers.
There are local I only got it yesterday.
if it is half an hour lecture, half an hour, half an hour, so it's 1.5 hours. And then simulation, go, so 2 hours of simulation. Then we have 1.5 hours of group work. See, that's the somewhere all the time. These people have well, I presume he's not going to do so. Say, oh, thanks. We got those little markers, microphone back at the projector. Well, we'll see. Oh, it's next week. I put out all this stuff like that. Patients, I've got all of them. I've got Derek, I've got David, I've got so I spend it up this room. But we got that. 6 hours. Hand over. Okay, that's his slide. That is what he's doing. So all about it. So it's very important that this is, I think it's not that I think that we are
Okay. Okay, good afternoon to all of us. Okay, we will begin our last topic today. Our last topic today is the wellness and well-being in anesthesia in Gatt Paradise, Bali. For Professor.
Good afternoon. This is a fun session, not about medicine or science or anything like that, but this is about how do you improve life in your departments, how do you live happily, how do you motivate people, you know, it's all about those sort of things. It also is quite important to everybody because while we spend a lot of time doing things in anesthesia that we've been taught, we must not ever become technicians. We don't want to be the people in the hospital
we want to be the people who drive the intensive care units. We want the people who drive accident and emergency centers. We want to be the people who run the anesthesia services, not just to give anesthetics. We're not some sort of slaves of the surgeons that do things, right? And first of all, I want to introduce you something I like to call the shell model. The shell model goes a bit like this. How do you test whether the team environment, basically, is conducive to wellness? So what I want to talk about is wellness. You know, how happy are you with your lives? How satisfied are you with your job? It's those sort of aspects that I want to explore. And remember that the shell model says that everything is enclosed within the shell, and within the shell is S for software, right? For example, software, I mean, do you have procedures for doing things? Do you have already pre-prepared models of what you want to do? Then we have H is the hardware, right? In order to do your jobs, do you have the right equipment to do your jobs? If you have no hemodynamic monitoring, then there's no point trying hemodynamic monitoring. There's no point doing cardiac surgery, for example, or any other surgery for that matter. Then is environment. Is your environment in a situation where it is conducive to productivity? You know, can you improve your life every day? What are the factors which change the way you do things, right? What gives you job satisfaction? How do you deal with stress, for example, in your environment? The L is for liveware. How do you get on with your colleagues? How does everybody in the department interact, right? Andre and I was just discussing, you know, something called human engineering, and there's whole departments now of people who produce engineering to improve all these attitudes in your departments. And finally, you have something, central liveware, right? And the central liveware is really you, the individual. Now, how does the individual living within the rest of the shell operate? And what are the elements which affect your lives every day? Why do you feel sometimes unhappy or unstable or threatened by your environment and the tasks which are given to you? And if you want to increase quality, you can only do so really by increasing well-being. The best people to produce good stuff are the people who are able, right, to manage their well-being. And in a way, it's a bit like having a balance of resilience, of job satisfaction, of well-being, as opposed to being fatigued all the time, to eventually get burnt out, and to be stressed. And this doesn't relate only to you, but it relates to everybody in your OR team, right? It is only when you get to that. How do we increase wellness? And the answer is one word: motivation. The way we achieve things depends very much on how we are motivated to do the things that we want to do. Some of us get into medicine because the money is good. Some of us get into medicine because because the training is good. Some of us get into medicine because when we went to university, we're the smartest kids on the block. So here's a room of the smartest kids on the block ever, right? It's taken a while to get through medicine. It's taken a while to get through your residencies. It'll eventually take time to get into anesthesia, and then to intensive care, and then to pain, and then all the other things. So by the time you're 40, basically, you get to a situation where you know everything there is to know in terms of knowledge, right? And it is the wellness and the motivation which will eventually serve you in good stead if you want proactivity, good job satisfaction, resilience with your job. So this can be put into a labor delivery suite, can be put into ICU, it can be put into your operating room. All of this knowledge revolves very much around motivation. Now, motivation is a number of things. You know, for example, the ability to meet the challenges of your work, the ability to perform better, and what are the incentives for you to perform better. Why would you want to do a GA Caesar the way I told you this morning, as opposed to doing it the old way that you've been taught, right? Again, in terms of career development, what do you want to do with your lives? Where do you want to go career-wise? And anesthesia, I tell you, is the best place to go of all the specialties. I'm not joking. Really, I think it's a great place to go. Plenty of liberty, plenty of control on your jobs eventually. When you're a trainee, you don't see these things, but eventually you will start to realize that you become the smartest guy on the block, and you're the guy they want to bring in when the brown stuff hits the fan, you know what I mean? You have the power, for example, to control your environment. And these are the elements of what motivates people. You know, you have plenty of opportunity for advancement. If the worst comes to the worst, you go to somewhere else that hasn't got sufficient supply of anesthetists, right? And they will pay you for doing this. It's not like it's all ordinary grind like other people being in engineering or being in making bottles of milk or something, right? This is very vastly different. And there's plenty of stuff to help you, you know, plenty of stuff from your seniors, from your leaders, from everybody else, plenty of staff, plenty of goals and objectives of work, because we believe in these things. And this is the elements of human engineering, basically, right? How do we make people, as opposed to machines, as opposed to perform better? Well, one of the best ways is self-motivation. Of course, many of us are driven by huge principles of self-motivation, right? You have to believe that you can do something before you can do something, right? The worst thing to kill motivation is not trying or not wanting to do, right? So I think in many ways, self-motivation is very important. Now you have to have there are two types of motivation. One are the intrinsic and the extrinsic. There are some things that drive you from inside. You love your job, it's interesting, it's enjoyable. You get to go to Bali every now and then, you know, to give lectures, you know what I mean? But also there's the extrinsic stuff. You do it because it leads eventually to a separable outcome. You do it because it makes sense for you to do it. It makes sense for you to give a good anesthetic and to save somebody's life, perhaps, whatever. Now, there are some things called what changes, that is, the things. And this is an old model, the Hackman and Oldham model, which was developed in the 1980s. There are some things within motivation that are bothering. For example, the job satisfaction will be driven by some core job characteristics. How varied is the variety in what you do? Are you always doing anesthesia for ACT every day of your life? No. The answer is sometimes you do a bit of this and sometimes you do a bit of that, right? The task identity is different for each of these elements. So we live very interesting lives in many ways. Everything is changing all the time. Different patients, different everything. The tasks are usually fairly short, you know. You give an anesthetic, you might even manage 4 or 5 a day. Sometimes in some places you manage 15 a day, right? The significance of the task is obvious, you know. You're doing it because somebody needs pain relief and needs to have surgery, and you are providing that significance. You have a great deal of autonomy. You can do whatever you want to. You can give any drugs you want to. You can use any equipment you want to. So you're very autonomous. You're working as single operators on your own. And this to me is a very important thing. You get good feedback from the job. The patient lives or the patient dies. The patient is sick or the patient is not sick, you know. So our job, the core characteristics of it are important. You also have these critical sociological states, right? What is the meaningfulness of your work, right? What does it mean to you, this work that you do, right? Again, you have a responsibility for the outcomes of your work. If your patient has bad pain relief post-operatively, your surgeon doesn't like you very much, you know, because it reflects on him. So basically having responsibility is good. Again, you have intimate knowledge of the outcomes and also of the results of your work activity, right? You do a nerve block and the nerve block doesn't work. You know immediately that you have to do something about fixing up that nerve block or doing some other alternative. Again, outcomes are very, in many cases you would say that we have a very high intrinsic work environment. You know, we work in operating theaters. We don't pick up garbage from the streets, you know what I mean? It's high motivation. Again, it's a lot of growth. You go from being the intern to the registrar to the residents and so on, and up you go, right? We have very high job satisfaction in anesthesia, very high job satisfaction. Nothing else, perhaps, and no other job in accountancy, in law, has a higher level of the job satisfactions that we get. We're lucky, you know what I mean, in many ways. And our work effectiveness is way beyond anybody else in the hospital. If you're a psychiatrist, you try a drug for 10 months, and sometimes it works and sometimes it doesn't work. With us, you do something and you get an effect, and if you don't get that effect, then you're disappointed, right? We don't use drugs that, like muscle relaxants, that don't work sometimes. They always work. Sometimes they work too well, sometimes, you know, they kill you, you know, but they're dangerous drugs that we use every day. So all of these modulators, right, which come from knowledge and special skills and a context of satisfactions and growth strength, which all come back together to produce a certain type of job. Now, again, I'm coming to something else that's a bit different, and this is called Ward's challenge to this characteristic model of having moderators of your life. And so the job characteristic model, which I've just shown you now by Hackman and Oldham, right? If you look at well-being from low to high, Hackman and Oldham sort of had the concept of what's that line in blue and purple, that things get better all the time and don't get better all the time, depending on what happened in your life. But in fact, Ward suggested the vitamin model. And he called it the vitamin model because, for example, vitamins C and D, for example, right? You start to get improvement, and then it plateaus out. You don't get, by taking more vitamin C, nothing happens, right? That's called the vitamin model. Whereas if you have vitamins like vitamin A and vitamin D, right, your satisfaction and well-being increased and then plateaued out, and then the more of the stuff, it actually made things worse. You suddenly started to get hypervitaminosis, and eventually you die from the hypervitaminosis. It produces a number of symptoms, chylosis and eye changes and so on, and eventually you die if you take too much A and D. So the vitamin model was not quite a straight line like was suggested initially, but more a rise and a plateau at best, and a rise and a plateau and a fall at worst. Now, when I ask you, how many of you go off to work every morning and ask yourself now, have a checklist. I mean, we have a checklist, you know, before we start surgery, right? Have you had your antibiotic, blah, 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 you know, all that nonsense that surgeons love to play, right? But, you know, is there anything wrong with me which is making me feel unwell? Do I have COVID today? Have I taken any medication in the last 12 hours? Have I consumed alcohol in the last 12 hours? I mean, some of these are important, right? You'd have to admit that this could be dangerous to the patient. Am I tired? Do I need more sleep? All residents are tired. All residents need more sleep. Like, am I under undue stress? All of us are under stress because that's the nature of our job. In fact, some of us love it. I mean, we live on stress. But you'll have to admit that sometimes, especially when you're more junior and you have less control, right? That stress can become undue stress. Do you ask yourself, am I emotional right now? Am I making the right decisions? Or are my decisions based on a whole number of other things? Have I had a sensible meal? I'm not sure I've had a sensible meal, but God, that was all right. Have I taken a good load of protein before I start my work in the morning? Do you ever ask these things? You know what I mean? Have I had breakfast this morning? Am I hydrated? Do I need to go to the bathroom? Have I got appropriate clothing on? Right? Do I need to wear personal protective equipment this morning? Right? Because there's a pandemic on, you know? How do I avoid distraction? For example, do I take my mobile phone into the operating theater? Of course you take it. I don't, sorry, I didn't say that. You know, have I put it away? I've left it in my locker to make sure I don't get disturbed by my stock exchange broker calling me about how my stocks are going. And so, what reduces wellness? And I'll put to you this: halt the 5 Bs. This is the halt the 5 Bs. What do we need to stop to improve? What are the 5 Bs? And these are the 4 Bs, sorry. These are hungry, angry, late, for start the list, and tired. Now, if you can stop those, you're already well on the journey to increasing wellness, right? And these are simple things, right, that we can do. And the 5 Bs are what? So, right, the 5 Bs are booze, alcohol, you know, too much bintang, babes and blokes, right? So this is interactions within the staff, between guys and girls and babes, that's exactly right. And nowadays between babes and blokes and blokes, but anyway, that's a different story. Baby, you have a baby at home that has to go to childcare this morning, right? You know, and this is the realities of today, you know what I mean? We do have that sort of problem, right? Banks, money, right? Are we having a crisis of money? Badly have my stocks in the stock exchange disappeared? And finally, bugs. Do we have any infections on board? Are we COVID affected this morning? You know what I mean? Those sort of things. So halt the 5 Bs. And the HALT is the first mnemonic, and is the second. So let's go back to that one. So that's halt, HALT, hungry, angry, late, and tired. And the 5 Bs are booze, babes, banks, babes and babies, bugs, and banks. Okay. Now stress. What is stress? I mean, if I asked any of you, what do you think stress is? To me, right, this is the best definition of stress I can find, which is the confusion created when one mind overrides the body's basic desire to choke the living daylights out of somebody, right? Somebody who desperately needs to be choked, right, because they're causing you angst, right? So it also results from situations. If a situation demands by an individual as exceeding your resources, and then you have stress. And that stress will often lead to very undesirable consequences. To be honest, 65% of all anesthetists in many studies are moderately stressed, right? 20% of anesthetists are very stressed. So this is amongst ourselves, you know, if we know this, it actually happens on a daily basis. And excessive stress eventually impairs your health, but also, more importantly, impairs your performance. So now, how do you cope with stress? Well, first of all, remember what happens when you're stressed. If you're stressed for a period, right, and then the stressor is removed, right, then everything is fine, right? You have time to recover. If your stressor happens, and then you don't have time to recover, and the next stressor comes in, and the next stressor comes in, and so on, then eventually it becomes not just a psychological problem, but a psychiatric problem, right, in that you haven't dealt with all these stressors coming in one after the other one. So if you have a baby that's sick at home, and at the same time you've also now got a patient that died on the operating table, or some catastrophe after catastrophe, these are the people who cannot manage stress eventually, and eventually become psychiatrically sick, right? So one of the best and most important is this thing called recovery time, right? Recovery time is the time it takes, right, to recover from a single stressor, as opposed to a lifetime of stress. The people who deal best with stress, and so eventually end up not ever being stressed, are the ones that have complete control over all the situations, which is possible to achieve, you know what I mean? And I think the greatest anesthetists in the world have exactly these sort of situations where nothing seems to faze them. They have sick patients, but they, you know, they deal with them as effectively as they can, and nothing generates stress. So the ones that are first of all, high demands. You know, if you're being asked to do far more than you're capable of, if you're a junior, for example, being left in an operating room on your own with no registrars and no seniors and no leaders and so on coming in, then you're in trouble. Again, a negative load, you know, where you're continuously being presented with negative patients, for example, where the recovery period is too short, so that all the additional effort to use to cope with the demand is such that it keeps going up and up. And eventually that leads to prolonged fatigue and emotional exhaustion. Now, if you can deal with all those things simultaneously when you're a junior, especially, you're a whiz. But nevertheless, we do it all the time. You know, if you go to the Institute for Emotional Stress, for example, how do you define emotional stress? Well, there's always a solution. Kill the other guy or throw him out the window or something, you know, and that solves everything, you know. But this is emotional stress now. Now, how do our job demands, impact on stress levels, all right? And this is the Karasek model, where you have on the left-hand side is the good things, the ability to control your environment, and your right-hand side, where the demands are, so it's basically a balance between the demands and your controls. Now, the demands can be all sorts of things. They can be physical, psychological, social, organizational, but all of them will require some sort of skills or psychological effort to actually control the demands. And the controls are the buffers, basically, the stuff that have an impact not only on the job demand, but also on the stress levels generated by those demands. I don't know if you get the concept here, but the control factor is defined with control latitude or decision latitude. How much power do you have if you have a difficult situation? Can't intubate, can't ventilate, something like that, right? How do you manage to have a decision tree which allows you to get out of that? And how much equipment do you have? How much staff help do you have? How well do you deal with the nurses around you, right, in controlling that situation? And the second one is freedom. Now, freedom comes with age, right? The older you get and the better you get, and the more and more freedom you have. I don't want to do this list this morning because I'm sick. I don't want to, you know, you can always say no to certain things that you don't particularly think as, you will tell a surgeon, I don't think you should be operating on this patient. Full stop. And I know that I'm the chief of anesthesia, and there's no way that I'm going to be doing that case for him, or any of my staff is going to be able to do that case for him, right? Because I'm not going to expose one of my juniors to, so freedom comes with time, with experience, and so on. But at the end, none of us really ever have complete freedom, except until we get to the ends of our life. Now, why is this important? Because if you look at workload and the work levels, then you this model from Karasek, which has been around since the early 80s, really, right? If you have on this axis control, the ability to control things, right? And on this axis demands, so this is demands and against controls, then you can have a situation where you have, for example, a high level of control and a low level of demands, then the strain is virtually zero. If on the other hand, you have high level of demands and low level of control, then you have a high strain situation. And if you think about it, if you have a low level of demand, but also a low level of control, then you end up in this box, which is passive. You don't do anything. All your job is to carry boxes, empty boxes, from here to there, or the trench every day. Low demand, but also no great interest. So it's a passive process. And you might be sitting in here, inactive, which is most of where anesthesia is. High demands, but also high levels of control. Then basically using the Karasek model, you can come to a situation where you know that everything is going to be fun today. It doesn't matter what you throw at me. I've got very high levels of control, right? And even if the demands are high, so what? Instead of working till 6 o'clock, we work till 8 o'clock tonight. You know, that's sort of philosophy. So low demand jobs with high demands, right, or high strain, and a low decision-making authority have increased levels of stress. Even the guy who's digging the trench, which has a low job demand, right, if the demands are that he has to produce a trench, right, that is 10 meters long when he's only capable of doing 5 meters long, then that produces stress. So stress is not a function entirely of demands. It's also a function of control, right? Likewise, low demanding jobs are usually not very demanding, but they're also very low in decision-making latitude. You dig the trench, you move those boxes, you know, it's something simple like that. So they've got very low decision latitude. And often they're very routine jobs, repetitive, non-challenging, and there's also low intrinsic motivation. Why would you want to spend a day moving boxes every day? The high demand jobs, which is anesthesia now, that have high control and met deadlines and so on, are usually very demanding because the decision latitude, the jobs are not experienced as stressful by the individuals. The intrinsic motivation comes from growth, development, improvement in your ability to do things. There are some problems with the Karasek model, and one of them is that individual characteristics now, your own psychological traits, the way you operate, are not considered in there. And also they're focused mostly on negative outcomes, on burnout, on stress, on strain, on sickness. So, you know, you have to be a bit careful with how you look at these models themselves. The other problem is, why are people satisfied or dissatisfied in the jobs, all right? And this is now known as Herzberg's. And Herzberg says that there are only two things. One is the motivators that I showed you at the beginning of this little part of this thing. But there's also another set, and that is the hygiene factors. I'll come to that in a moment. But basically, performance, satisfaction and dissatisfaction, right, are dependent on, and the amount of performance increase or decrease depends on the balance of the two motivators, right? Now, and the hygiene factors. Now, when you come to satisfaction and dissatisfaction with your jobs, on the left-hand side, you have your motivators, whether people trust you, whether you recognize them what you do, whether your picture gets put on the wall because you've been a goodie, right? Whether you potential for growth within the department is great. How does the department actually value you as a person? How does the department allow you to advance within your department? I give you more responsibility, but only enough responsibility to be able to manage. And of course, it's to deal with the work itself. You know, if you live in a bad environment, it's a bit hard to get motivated, you know. But, you know, you live in paradise, so you might as well enjoy it. Motivators are only those things which promote action over time. And therefore, motivators will eventually promote long-running attitudes and much more satisfaction. The presence of motivators has the potential, if we can give you a set of motivators that are right, of producing great job satisfaction internally, but on the other hand, if you don't have those motivators, it doesn't necessarily produce dissatisfaction in everybody. So increasing the motivation increases the satisfaction, right? But the fact that there are no motivators, right, like I'm doing it for the money, even that, some people are happy with that. You know, it doesn't necessarily produce dissatisfaction. The hygiene factors, I don't know why I call them the hygiene factors, but basically are elements not related to the job itself, but which in some people will contribute something. For example, are you paid well? What is your salary? What are your interpersonal relationships with your subordinates, with your peers, with your supervisor? Right? Technical supervision, company policy, administration issues, right? Working conditions, factors of personal life, your status, your job security. Again, it's interesting in that the hygiene factors are not all important to everybody. I couldn't care less how much I earn, to be honest. You know, I'm not a money person. And many doctors are like this. You know, this is not about money. This is about job satisfaction. I'd rather be given a PhD than be given $100,000. You know what I mean? Why? Because a PhD to me means something. But again, hygiene factors can cause temporary action, and the presence of these factors causes no satisfaction, but their absence, on the other hand, can cause great dissatisfaction. For example, if you're not receiving sufficient salary to hold your family, right, to be able to take food home, then it doesn't necessarily produce satisfaction, but it doesn't necessarily either sometimes cause dissatisfaction. On the other hand, it can cause great dissatisfaction that you don't receive enough salary, right? Mind you, Herzberg is as far back as the 1950s, and was basically based on 200 engineers and accountants, but the policy is still there. What increases satisfaction and what increases dissatisfaction? Now, the ANTS framework has been around also for a very long time, and it's very much about how you manage yourself on a number of things. For example, if you have a task, you have to give an anesthetic for a 95-year-old who's moribund, right? How much do you plan and prepare? Are you able to prioritize things? Are you in a capacity to maintain standards? How can you identify and utilize your resources? All of these are very important aspects, right? Again, when it comes to team working, how do you coordinate activities? How do you exchange information? How do you use assertiveness and authority in producing what you want to achieve? How do you assess capabilities, not only of yourself, but all those people around you, you know? Are you putting stress on other people by thinking that they all have to perform like you do, right? Do you support others? Again, situational awareness, I think it's very important that you're able at all times to gather information, to process that information, to then use it to go in a particular direction. And this is where the new human engineering is all about. In your situation, can you recognize the hazards? Can you understand the hazards? Can you anticipate them? And again, when it comes to decision making, can I identify the options? Can I balance the risks and benefits? And am I able to evaluate? And then you can have a scoring system of some sort, right? Poor, marginal, acceptable, doesn't matter. Now, where are the sources of stress for anesthetists? And this is probably an important slide in many ways, because all of us live under these conditions. And the first one of them is lack of control. When you can't control your environment, right, then you are in big trouble, basically, when it comes to, and this is related to time management. You know, do I have too many cases to do today? Has the chief forgotten that, you know, the second patient, you know, has a bleeding diathesis, and we're going to have to be very careful with bleeding situations? How is the work planned? You know, have I put the diabetics up front? Have I done all those things that require for me to plan my day? And how much control do I have? As a resident, you have hardly any control at all. The surgeon decides he wants to do something, your consultant anesthetist decides he wants to do something else, and then they have a bun fight themselves, and then they come up with some sort of plan. But from your point of view, you are told, this is what we're going to do today. Risk management. How can I reduce my risk? I'm not good at epidurals, right? I had to have 3 blood patches this month, you know, because I've had a dural puncture. How do I reduce the risk for the next patient, right? how I reduce my risk, right? So some of them are to do with control, but others are situational, right? Situations are related to skills. I don't know how to do a bulbar plexus block, you know what I mean? And they're asking me to do a retrobulbar block, you know what I mean, on somebody's eye. How do I get that? You can get Professor Van Zunder to come and tell you how to do them, you know what I mean? But in the end, you know, if you don't know how to control something, then some are skills related. You have it or you don't have it. Others have to do with interpersonal conflicts between operators, between you and your boss, between the nurse who's helping you today. And now we start to bring in a lot of additional baggage into the lives of people, you know what I mean? Where, you know, you don't get on with so-and-so, you don't, you know. Also that there's the doubt and responsibility pressure. You know, am I sure I'm not going to cause a retrobulbar bleed in doing a retrobulbar block, right? Why should I be responsible for something I'm not very good at, you know? And then there are all the life and career worries, you know what I mean? Again, the babes and the blokes and so on, and the interpersonal relationships and the, you know. So basically all of us need to find a place we can go to, stress-free zone. For me, the stress-free zone today is going to be on the beach in Sanur this afternoon after I've finished with this. But for everybody, we all have to have that sort of thing, like sleep. And, you know, an ability to take care of our children. You know, this is a slide from a firm in the United States who are trial lawyers, was his. You know, no, it isn't it's a Porsche, sorry, it's not a Maserati. Okay? Again, fatigue, right? Fatigue has long been known. You know, if you're asked to pin the tail on a donkey after an 8-hour shift, right? You can do it. But put that 2 shifts, which is very common with residents, mind you, 16-hour shifts, not only unheard of, in some places almost mandatory. By the time you go to 20 hours working, you're absolutely useless. You know, you make decisions, bad decisions. You forget what you're going to do. This is why I'm getting towards that point right now, right? So fatigue is important. And once you get beyond 20 hours, what's the point of being? Now, what has COVID produced with regards to stresses? These are doctors in India in November 2020, right? So basically, they were only right through COVID-1 at this stage, right? You can see the numbers were high, large, right? 34% of them were physicians, 29% were interns and residents, 66% worked in public hospitals, 52% were female, and 41% were more than 30 years old. Now, 87% had already been involved in direct COVID care. And 43% of those were seeing more than 10 patients per day who had COVID. So a nice study, basically, in many ways, right? Found out was incredible. That 47% of all these doctors, right? Basically, they were all in Pune and Mumbai, right? 47% had depression, 50% had anxiety, and 45% had a low quality of life. Why? Because the stresses were interesting, right? You had increased work pressures with COVID, a worsening work environment. They had concerns about the epidemic, and some of them were family related. The families were getting sick, right? So COVID was an enormous stressor for all these doctors, and they weren't even anesthetists, right? But 46% had combined anxiety, depression, and all felt that they had a decreased, so now this is not just low quality of life, whatever they were before, all of them said that COVID had produced a decreased quality of life. Now, personal health, right? I've told you already that amongst who was mostly affected, right? The severe depressions were higher in the residents and the interns. Surprised? Not particularly. Consultants had much less. Consultant could go home and not do any work at all, basically. I'm talking about India. It doesn't happen in Bali, of course. Severe anxiety, again, not much different really for the two groups. But again, combined, so not huge differences, but nevertheless, they're obvious, okay? So how do you fix up your personal health? All of you, please, have your own personal GP. Don't prescribe for yourself, don't prescribe for your family. Even if you do that every now and then, like fill in the prescriptions, that's fine. But most of you, all of you need to have a GP, somebody who you can talk to. Don't self-medicate. Doctors are very poor diagnosticians when it comes to diagnosis their own illnesses, and especially amongst residents, you're all things that you're superhuman, you know what I mean? You're supermen and superwomen, right? Don't do that. And medication, self-medicating is a dangerous thing, especially for the important psychiatric thing. Have breakfast, have lunch, right? Stop, exercise. Exercise doesn't mean going to the gym, right? Exercise doesn't mean going for a swim every day. Exercise means keep moving all the time. Don't stop, ever. Make time for leisure, right? Music, books, art, conversation. It doesn't matter. Whatever you do, have fun doing this stuff, right? Cuddles, sex, have these things. They're not there for. If you're sick, don't come to hospital. Please don't come to hospital. Take sick leave, right? That's what you have an annual review. You check your car every year because you have to, because the government says that you have to get a little pink slip for everybody, for the car. Have the same for yourselves. So, when it comes to fatigue, right, remember that, that you must be able to diagnose when you're experiencing fatigue. And if I were you, I would once again have a checklist, right? The checklist is there a lack of awareness? For example, with my checklists, am I checking my checklists? Am I doing that sort of job? Right? Is my motor skill normal? What's my hand-eye coordination like? Am I slower today? Do I have obvious tiredness, drooping head, staring, half-closed eyes? I see a lot of that around the room this morning, this afternoon. And that comes from having eaten too much food, Diminished vision, difficulty in focusing, slow reaction times, very bad short-term memory. I can't remember the name of the girl I met this afternoon, you know what I mean? It's like that sort of stuff. Do I have channeling of my concentrations or distractions? Can I focus on a single thing without losing overview? Am I drifting in and out of sleep because I'm so tired, I'm buggered, Is there an increasing number of mistakes, poor judgment, errors, poor decisions, no decisions at all? And then there are all the abnormal modes later on. The erratic changes in mood, depression, periodically being elated or energetic, and then diminished standards. So fatigue has an enormous impact on human performance. Now, that little sign you had, the ideal anesthesiologist. 5 years ago, I used to live over there. And it's a great pity that they moved it to the back of the room, right? Because that is really what an anesthetist should look like, right? I'm not joking. I think that is a great little poster. I've seen it many times. I've never seen it like yours put at the front of your room, right? And I think that's where it belongs. Now, you all recognize these people, right? There are two people here. This is the older style anesthetist. What was the older style anesthetist like? Decisive, self-reliant, authoritarian. No, they never have a difficult airway. We'll get a tube in. They don't have any blood loss. No, 5 liters is nothing. Hypotension, that's for the wimps. This is the guy or girl who turns off all her alarms, because alarms are annoying. The noise is too big, right? There's no proper assessment really. There's three. They just walk along, just give an anesthetic, tie a pentose sucks, off we go. You know what I mean? They work the day after a night on call. You know what I mean? They're never fatigued. Safe hours are just for the wusses, for the weak ones. I'm one of the weak ones. And again, my personal problems stay at home. I'm divorced. My third marriage is going on the rocks. But those are nothing to do with anesthesia. And you don't need too much monitoring, you know. If you have a blood pressure cuff, you're lucky, you know something. You know, at least you got a blood pressure cuff. It's that sort of thing, you know. These are people who don't even put an ECG on some patients, you know what I mean? It's like, this is the oldest style anesthetist. Now, is that good or bad? Well, there's also the low-risk anesthetist, somebody who anticipates problems, checks the machine very carefully every day, labels all the syringes, expects some pleasant surprises. They expect inputs from others. Listen, I think this tube is in the esophagus, not in the airway, you know. They accept that sort of thing. The other ones will just go on, you know. They're willing to revise hypothesis, you know. I think this is an esophageal intubation, but no, it happens to be a tracheoesophageal fistula, you know, that sort of stuff. They can fix minor hemodynamic deviations and do it all the time. They don't wait till the blood pressure drops to 20% below the baseline. As soon as they see a hemodynamic change, boom, they fix it. They recognize fatigue. They recognize personal worry. They take days off to fix those things. And to them, speed is an accomplishment, not an aim. And this is probably very important. There are some people who think that being fast is good. And if you live in a department, right, it's certainly very true that speed is a good thing to have, but not when it becomes an aim of your daily lives. Only when you use it because you know you're doing things safely anyway. Now, really, if you think about it, you know, if you look at yourself, I think the staff teams or the people who live around us produce an enormous amount of support for us every day of our lives. We don't realize this, but if you've got a good department, you also organize yourself so that you know exactly what is happening within your department. If you're a good chief of anesthesia, you take care of all of these things. Let me give you an example, right? And to me, this is a great investment from your departmental administrators in wellness. Level 1A is protection of the staff. Immediately there is a problem. And you got your director of anesthesia, there's the pod leader, whatever you call those. You have mentors, people who've taken care of you in the past, right? And you have the consultant on call. So basically already you have one level. Level 1B is now the other people around you, your family, your friends, your workmates, and the staff in the operating room, all of whom should be helping each other all the time anyway, if you want to produce wellness of a department now. Then you have the level 2 guys. You know, we've got things like psychologists in the hospital, we have internal welfare, and in our case, the College of Anesthetists, Special Interest Group, who's interested in welfare. You have liaison psychiatry, you have the employee assistance service when things go wrong in your lives. And then you have the really big guys, the lawyers, the medical defense unions, the doctors' health advisory services, the finance and administration support, the counseling, the psychiatry. But all of them are like little nests inside each other. And if you have all those levels, then forever you will be a happy person. Because if you have good relationships in all those situations, even when things really go wrong, when you do have an unexpected death on the operating table, when you have a medical or legal problem, you got so much support that nobody else has as much support as those around you. Now, for this one, I am very indebted to Vera Musen, who's actually Professor Van Zunder's partner. And why have I shown you this? Because this is a study of fatigue amongst nurse anesthetists, right? So we're talking the Netherlands now, we're talking nurse anesthetists, and we have compared them with people who have chronic fatigue syndrome, multiple sclerosis, some sort of gut symptoms, you know, bad bowels, that sort of stuff, CVAs, who are in the military, and who are ex-oncology patients. So these are not good situations to be in if you're a person, right? And with the nurse, and then we looked at subjective fatigue, or she looked at it, say, at low physical activity, at poor motivation, at lack of concentration, and of total fatigue. And the numbers are incredible. You know, nurse anesthetists, for example, over here, in total fatigue, have compared to people with multiple sclerosis. Over here, you know, you have nurse anesthetists comparing with chronic fatigue syndromes. You know, It is incredible, that, even in subjective fatigue, 31% of nurses felt that subjectively they were fatigued. Now, we have a system in Australia called the Anesthesia Incident Monitoring System, called AIMS, right? And ACEs and AIMS are both systems that look at what's happened, what poor incidents have happened. In 2% of all incidents that happen in an operating theater, adverse ones, I mean, fatigue comes up in 2.7 of all incidents. So fatigue is an important thing. And we all carry a very personal obligation, right? We carry a personal obligation to not be fatigued and still work, right? Why? Because that is not safe and effective service, right? Do something about it. If your eyes are closing, go to sleep, even now. Now, we always compare ourselves to pilots, because the task of anesthesia are like the task of pilots, right? In many ways, we have a flight going up, maintenance, and then flight coming down. Easy. Again, we always depend on somebody else. And this is what resource management and human factors management is all about. Right? For example, these are two pilots arguing, sure, I believe in resource management. You're the resource and I'm the management, right? But it's not quite like that. So basically, individual skills, human factors, and crew coordination is what crew resource management is all about. So the pilots call this CRM. And have a look at this, right? The question was, when I'm fatigued, right, do I perform effectively in critical points? For example, well, is this dying on me? Gracias. Okay. So CRM, right? When they were asked this question, before anybody started doing anything, 40% said that when I am fatigued, right, I can still perform well when a crisis happens. In their case, a fire in an engine or something along those lines. In our case, a failed epidural, for example, at cesarean section. Once they were taught, though, the number of people came down closer to 30%, and then to 25%. And eventually, after a CRM in 1994, they had managed to reduce it from 40% to 20% of people felt that they could still perform well, right? But look what happens with doctors, right? Doctors without training, in 60% of situations, they could perform all right when they were fatigued, and yet they were having a crisis because they felt that they could lift themselves to get up above the level of that fatigue. Now, in England, this has been a big bone of contention for the last 5 years. Anesthesia trainees are receiving a lot of simulation training, right, in non-technical skills, in human resource management. And these are known as human factors training, which improves your performance, right? And indeed, if you look at these things, right, what do we do as an OR team to improve our attitudes to our colleagues, to the surgeons, to the nurses and the residents, right? Every unit has its own level of performance, right? It can be pathological. Who cares? As long as we're not caught. That sort of attitude. Then you have the next level up, which is reactive. Safety is important, and we do a lot to make sure we don't have an accident. But then comes the next level up, which is calculative. We have systems in place. We have actually engineered the environment, right, to manage hazards. We have the proactive ones, right, who say, well, safety, leadership, and values drive our core performance functions. And finally, you have generative, where HSC, where this performance is the business around here. It's our level of control. And as you go from there to there, you become increasingly informed, and you also increase trust within the teams and accountability within the teams. Nobody's afraid to say, I stuffed up this morning, right? Nobody's afraid to say, I had an incident. No, because they know that the main aim of this, and this is something called a safety culture. Right? If we can produce that safety culture, then we know we're sweet. And I'm coming to the end now, and because I'm getting to this point myself of burnout, right? And we all know what burnout is. You don't want to be an anesthetist anymore. You don't want to do medicine anymore. You want to go fishing, for the rest of your life. We all know what burnout is. Interestingly, amongst anesthetists, the level of burnout is high, amongst 40%. We live in very high demand jobs, right? The demands change all the time, right? And what causes this burnout, right? Well, as I told you earlier on, you start off with stresses. The stresses disturb your balance. You can have a challenge on your employee, something called adaptation, and then become our coping behaviors, right? The challenges are also related to your own personality traits. You're obsessive compulsive, you are a depressive. If your coping behaviors are all right, then you restore your balance, you restore your optimal performance, and then you can deal with the next stressor. But if you don't cope, then the stress responses come in. You then start to get muscle tension, burnout symptoms, sickness, and so on. And then you burn out completely. You have to leave the job, you know what I mean? So really, and again, this is about well-being in Scotland this time, not in England. But again, you can see, right, that when morale is low, right, supporting each other goes a long way to help reduce burnout and increase resilience. This study was actually generated by a high incidence of suicide amongst anesthetists, especially males, right? But also females were heavily affected, right? And with all of these suicides, there was always something, having a car accident, for example, that seemed to precipitate it, not having enough money to pay the rent, that sort of stuff, or not getting enough sleep. All of these things eventually. So if I had to come back to a summary of all I've said this afternoon, right, in short, number one, take control. Always control your environment. Always make sure you have the right drugs. Always make sure, and if you don't have them, make a noise about it. This is not the best anesthetic I can give, right? Please buy me that machine. Please do. And again, it's not at your level mainly, it's obviously at your chief's level, but you need to have chiefs that go into bat for you in making your environment as best as they can. Get organized. Share your responsibilities. Talk to each other about how I can help you and you can help me, right? Keep up to date. It's very hard to keep up to date on anesthesia nowadays. The number of papers coming out every single day is enormous, but that doesn't mean you can't keep up to date. You can bring people like me who will summarize 10 years worth of work in one 2-hour period, so schedule breaks. Relieve each other in the operating theaters, when you're working every day. Keep healthy and have sex. Okay, so that is my summary. So with managing fatigue, always have a plan. And the plan is simple, right? I mean, you all know how to manage fatigue if you want to. Departments must manage fatigue. It's not a matter of you managing fatigue only. If the department is loading on double shifts on you, because they haven't got enough staff, because they're all out with COVID, then tell them that we can't do this forever. Job plans on a daily basis should not lead to fatigue. You shouldn't have to every day run your operating theaters till 8 o'clock in the evening, right? In Boston, we had this lovely situation where at 3:30, the evening shift came on and took off all the cases by 5 o'clock. Very good handovers, very good, all those sort of things. But by 5 o'clock, everybody went home, one way or the other. And sometimes you got away at 3:30, which is good. Anesthetists should have routine breaks. They should be labeled into the day's work. They should be such that the routine breaks is you can have breakfast, you can go out for morning tea, you can go out to afternoon coffee, whatever, right? But you have to have routine breaks. Now, if you're doing long cases, you don't check the equipment when you start. You check your equipment on regular basis, and you also do better than that, right? When you have long cases, we even sometimes move the staff around, so that it's the same people out managing them when they start as when they finish. Because every handover is a very good time to find out small things that need to be fixed. Again, you should have on-call rooms. It's not a matter of just, giving you an hour off. You need to go and find a chair in fact, we call it the Golden Wing Lounge because it's very pretty, right? But we have these recliners where the seats come up. You can actually go and have a quick nap, a micro nap for a while. Okay. Again, you should have regular quality refreshments, right? Even if it's just water, that's quality for you, best quality, right? But you have to have refreshments all the time. And this is what produces the good free zone, the stress-free zone. Sleep, don't work and work and work and work, don't take off. So in the world, if you look at eyewitness news, it's always plague and pestilence and death and earthquakes and all sorts of terrible things happening, tsunamis and cyclones and so on. And what is the good news? That stress, fatigue, burnout, plus all the other things that happen in each of your countries, coronavirus, bushfires, recession, global financial crisis, terrorist attacks, right? We can achieve this quite easily, a stress-free area. But how? By increasing our team's resilience in the operating room, by improving wellness, by having better health, increased fitness, better team performance, friendship, camaraderie, and better workflow patterns. This is coming to the end of my presentation. I want to go back, though, before I finish, to the shell model, which I started with, and show you how all this ties together in 10 seconds. Okay, so the shell now has been rearranged, right? Where the central liveware is now in the middle. That's you, right? Where the hardware, right, means that we have to design our environment and look what systems we have available to ourselves in our particular situations. In Bali, it might be different to Sydney, right? But it doesn't matter. Each of your systems should be optimized. The E is important because safety culture doesn't cost money. Situational awareness doesn't cost money. Good risk management doesn't cost money. So you can do this without having a great deal of extra cash. The L, which is called liveware, is to do with communication, teamwork, fellowship, friendship, camaraderie, collegiality. How do we do those? Easy. But in the end, the important bit is you. It's your human performance. It's the fatigue, the stress, the alcohol, the drugs, knowledge of how to do work and having special skills, having the right attitudes, time management, planning. All of those can come together to produce all improvements in all those areas without doing very much, really, overall. And that's where I want to stop. To me, there's a little important message. The only way to guarantee failure in anybody is never to try. So you always have to try to do your best at all times. And with that, terima kasih.
Okay, thank you. Once more, we give applause to Professor Stephen Gatt. Okay, so now we come to the end of our last session. There will be a Q&A and session. Is there any question or any comment from the audience? You may raise your hand.
I love this session because it's kind of being psychiatrist. You can tell me all your problems. Yes, Cindy.
Professor, thank you for presentations. I know it would be embarrassing, but maybe you have read about the risk of substance abuse in anesthesia is very high, and especially it is so related with the burnout that you have been talked to. And obviously, even if we're not telling you this. We have several histories of drug abuse between us, my seniors, my juniors, and maybe one of them, but we still don't know yet. At least starting from maybe just combinations between paracetamol and several thing else, or maybe when they get drunk, they, sometimes they mix something, and I know it. If something happened and if they get caught up and they are already in the middle or maybe senior year of registrars, as if in just a certain amount of time they would be registered anesthetist, what would you think and what is your opinion about it? Because this habit
I am
is
a great expert on this. My brother,
yeah.
who's only a year and a half younger than I am, committed
Yes.
suicide at age 23. Right?
Okay.
I was still in the registrar years.
Okay.
Right? And since then, I've always been fascinated by substance. In fact, in his case, it wasn't substance abuse. It was actually a side effect of a drug called dextropromoxifene, which has been banned across the world, except South Africa and France, because this drug actually produced high incidences of suicidal ideation. So I tell you, I'm an expert on this.
Okay.
I've now spent 45 years. I actually used to accept people who needed rehabilitation from substance abuse. I've succeeded with 5. The other one killed herself. Prof. Right? So the drugs that are involved are often atypical anesthetists, right? So it is things like propofol, for example. Propofol abuse is really one of the most dangerous things that you can have, because you have, once you're under, you have no control from then onwards as to what happens. You stop breathing, right? The importance, first of all, is to actually shelter these people entirely. So you telling me it's a senior resident, I think it's totally inappropriate. That person should be shielded at all times. Nobody in the department is to know about this except yourself or your chief, right? Because the only way to protect those people out of the problem is actually to be able to, and rehabilitate them eventually, is to be able to offer the option that nobody else is watching them all the time. There's nothing worse than being a substance abuser and living in what we call siege mentality all your life, where, everybody's watching you all the time. Are you doing it? Are you not doing it? Even when you're not doing it, you're still guilty by past history, sort of thing. So protecting these individuals is very, very important. Secondly, remember that some of my best consultants at one stage were the people I rehabilitated. And for the rest of their lives, they ended up being the most fabulous anesthetists. One of my neurosurgical anesthetists, for example, even after he became 70, he used to come every day, right? And I'd say to this guy, you're not going to resign this year. You get it? I'm not retiring you. You're the best I've got. Go away. And eventually when he got to age 75, he said, but this is one of these people who had been one of these so-called drug abusers. Again, we've had terrible stories. When you live in anesthesia for 45 years, you have terrible situations. The girlfriend of one anesthetist, for example, who overdosed on paracetamol of all things and ended up being dialyzed and eventually having, artificial liver and, oh my God, anyway. It's a bad way to die, right? Paracetamol. So be patient with these people. What they need is your support, not your anger, right? What they need is your realizing that there for the grace of God go I. You could be that person, right? So always think of that person as somebody who must not be allowed to become a victim. They must always be supported to become able to rehabilitate themselves to a normal anesthesia life. As to what you do, I think that the ones that used to come to me used to come from the medical board or from APRA, which is the regulator, and saying, look, this is the 3rd round, we're going to strike him off the register. And I'd say, look, just give me one more chance. Give me one more chance. I promise that I will do the urine samples every day with them. I won't even tell them when I'm coming. I will leave the door of the toilet open so they can actually give me their samples. But don't worry, we will do this formally. If I find that they're positive at any stage, I would also ask for an extension of time to try for a couple more weeks. Because sometimes failing once is not failing all the time. It's just failing once. We all have times, highs and lows in our lives. And when it comes to the lows, different people deal with it in different ways, And, the problems might not be anything that you think they have to do with anesthesia. They might be sexuality problems. They might be, bad relationships. They might be divorces and marital discord. So what I would say to you is be patient with those people. They're good guys. It's just they've taken a wrong fork for a while. And I'm sure if you try hard enough, you can bring them all back, I don't know if you agree with this or not. But one of the important things to do is to hide exactly from everybody else the fact that they are these people. Don't even look at them, right? Any different, the way you look at them, to look at anybody else. These are not hazards to the department. These are actually people who are like you, but need to be treated a bit differently for a while. And sometimes we had to pull them out. In one case, for example, we had to pull them out of anesthesia altogether because of the nature of the drugs involved, in usage. What did we do? We put him in pain, of all places. But anyway, we're the capacity, but in pain without the capacity to handle the medications. He'd order them, he'd prescribe them, but he never dispensed them. Okay, so I don't know if that answers your question, Cindy, but I think, these are very sensitive things.
Thank you.
In my entire career, I've had the 5 that were specifically sent to me from outside. But again, we had probably about 20 people who, in the end, we thought, we're not sure, but but it's all right. Okay, and some of them get away. Most of them get away. Not just get away. Get away from the disease. This is what I'm saying. This is a disease, after all. How would you manage somebody who told you in the room that they had hypertension or diabetes? I'm telling you now, I'm a diabetic. How would you manage that? Nothing. Just, so long as you can manage. And drug addiction and so on, substance abuse is no different. That's another disease. It needs to be fixed. Sometimes it's not even a disease, it's just an aberration. If you deal like you might be suggesting that you deal with them, then I suggest to you that you'll have a lot of people like this, and secondly, that you'll have a lot of people who would otherwise have been great people eventually, right? Great individuals and so on, but who haven't been given the chance, basically, and destroy their careers. This is very important stuff. Even reporting them to the medical board, for example. I think it's something that you should do with great reluctance, because once they go down that pathway of being held to account all the time, if you can have a nice chat with them and offer them the pathways to rehabilitation before you get to reporting to the medical board, it will be enough.
In your opinion, are you saying that there still could be deemed responsible for making decisions because sometimes they become unprofessional in work, right? Because they're using it. Even if I'm just having a drink before I get to work, it could be deemed unprofessional. And also the second one is how many times or how could I spare some times before I report them to another authorities or maybe psychiatrists?
You should in a way report them immediately to your immediate superior. So that's no doubt about it. Now there are 2 people now involved with managing this, right? So that's the immediate thing. Let me tell you a little story. When I arrived in Boston, right, the chief at Harvard was Ben Covino, one of the greatest anesthetists of all time, and he was absolutely destroyed. Right, here's the chief of anesthesia in the most popular anesthesia program in the country, huge numbers of people involved, and he had 3 incidents in 1 year. Right, one was a case of supposed rape. Portuguese girl had gone down to Cape Cod, which is basically with 5 male residents. Had a history before of being, I wouldn't say promiscuous, but certainly, a bit loose on the moral side, right? And she, 10 days after they all came back, rape, gang rape by 5 people, you know, blah, blah, blah. Huge amounts of money involved in the lawsuits, you know what I mean? What do you do as a chief of anesthesia? You know, these are 5 of your residents. I mean, this is like not just one. And then one of them was Iranian, and he got caught coming back to London with salami, which was an illegal import, you know, so basically rape, doctor, you know, bringing in illegal imports into the country. Everybody thought they were drugs, and they weren't drugs at all. They were, you know, meat. You know, it's like that sort of thing. And another one was a really lovely New Zealand guy who eventually just left anesthesia, you know, because he couldn't take this. Then the Portuguese community gets involved. The second case was a case where they found somebody with a propofol syringe hanging out of in the toilets at the Brigham. Not a nice scene. The third one was a flasher, you know, exposing himself on, and the Brigham is built of 4 towers like this and bridges, and this guy was exposing himself on the bridges. How does a nice guy, Catholic, religious, how does this guy handle this sort of situation? You know, I mean, 3 cases in 1 year. He kept asking me, "See, are you one of these people? You know what I mean? You know, would you ever do this to me? You know what I mean? As a chief." All I'm saying is these things eventually resolve themselves. What action should you take? Always the minimum you can take, the maximum you can do to improve the situation, and the minimum we can do, right, to report those cases, right? Does that, you get the message there? All right. Anybody else want to pour out their souls and their hearts? How about we go for a swim, eh?
Okay, anybody else has question or comment regarding our last topic today?
Thank you all. It's been a long day. Selamat siang.
Okay, thank you. We will like to say thank you once again. We would like to express our gratitude to our special speaker today, Professor Stephen Gatt. Thank you for sharing the knowledge and giving us the opportunity to extend our insight in anesthesia and also in well-being and wellness. And we hope you will enjoy your stay in Bali, and we will wish to see you again later in the future. Yes. Yeah, okay. Thank you very much. So that's it. That's it for our lectures today.
Unless you close the shop for COVID.
We would like to take pictures together with your professor today.
Okay.